You tell me exactly when it is. Madam?
Praveen, I'm
Madam,
ready.
shall we? Okay, ma'am. 45, 46 have joined, ma'am, already. They will be, in the due course of introduction, will join. We'll
Okay.
start, ma'am.
Sure.
So, respected seniors, colleagues, and my dear postgraduates, good evening. On behalf of ISA Vishakhapatnam City Branch, it gives me immense pleasure to welcome you all to this third session of postgraduate orientation and discussion series. So to begin with, let us have an auspicious start with prayer of Goddess Saraswati.
Good evening, sir.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
Today, we are honored to have Dr. Indrani Hemant Kumar, Madam, Professor and Head of the Department of Anesthesia, Pain and Critical Care, Symbiosis Medical College for Women, Pune, as the guest speaker. Madam is the Governing Council member of ISA National Headquarters. She has authored around 12 chapters in various standard textbooks. She has led various national societies of anesthesia, and this reflects her dedication to her specialty. Interestingly, Madam is a passionate classical dancer, and she carries that grace, discipline, and positive energy into academics, making her teaching clear, simple, and easy for students to connect with. It is also my privilege to extend a warm welcome to our respected moderators this evening, Dr. A.S. Kameshwara sir, past President ISA National and ISSP, Dr. V. Kuchel Babu sir, past President ISA National, Dr. K. Srilakshmi Madam, Professor and Head of the Department of Andhra Medical College, for guiding this academic session. In the second segment, we shall have a case presentation by Dr. Amala Jyothi, postgraduate of Government Medical College, Srikakulam, on anesthetic considerations for an obese patient posted for lap cholecystectomy. And the examiners for that case discussion would be Dr. TDP Sublakshmi Madam, Professor and Head of the Department, GMC Srikakulam, Dr. D. Jaidir Babu Sir, Professor and Head of the Department, GMC Vijayanagaram, and Dr. Manjula Ramsali Madam, Head of the Department, Seven Hills Hospital. So before starting the session, a brief introductory remarks by the President of City Branch, Dr. Anuradha Madam.
Good evening, everyone. On behalf of the Indian Society of Anesthesiologists, Vizag branch, a warm welcome to all respected faculty, postgraduate students, and guests joining us for this postgraduate orientation and discussion series. I welcome to our moderators, Dr. A.S. Kameshwar sir, past president, ISN National and ISSP. Welcome, sir. And
Thank
I
you.
welcome Happy New Year, sir.
Thank you.
And I welcome Dr. V. Kuchel Babu, sir, past president, ISN National. Welcome, sir.
Thank you.
I would like to invite Dr. K. Srilakshmi, ma'am, professor and HOD, Andhra Medical College. Welcome, ma'am. And Dr. TDP Subbalakshmi, professor and HOD, GMC Srikakulam. Welcome, ma'am. Dr. D. Jaidir Babu, professor and HOD, GMC Vijayanagaram. Welcome, sir. And Dr. Manjula Ramsali, head of the Department of Anesthesiology, MGM Seven Hills Hospital.
Thank
Welcome,
you, brother.
welcome, Manjula. We are privileged to host Dr. Indrani Hemant Kumar, professor and head of the anesthesiology at Symbiosis Medical College for Women, Pune, and a distinguished leader in the field with fellowship from the Indian College of Anesthesiologists and expertise in onco anesthesia. Thank you, ma'am, for sharing your invaluable insights with our postgraduates today. Welcome, ma'am.
Thank you so much,
Good
Anuradha.
evening, madam.
Good evening, sir.
Very nice of seeing you after a long time.
Yes, sir. Always a pleasure, sir.
Thank
Ma'am,
you.
I am your fan, ma'am. First time I saw and read about the mitral stenosis in YouTube.
Oh my
So
God.
that is very nice and very. You told about the very laboratory. So I wrote the topic, everything. It's almost 10 pages, ma'am. Very nice, ma'am.
So
That
nice to hear
presentation,
this.
mitral stenosis. Welcome, ma'am. I would like to extend my heartfelt gratitude to the ISN national team for their unwavering support in fostering such online initiatives that connect branches nationwide and promote academic excellence. Thank you. Over to Praveen.
We are also having Dr. Durga Prasad sir, President of ISA AP, with us. Sir. Okay. So, sir. We look for
Is there a connection issue?
No, ma'am. It is the
Okay.
Good evening, all.
yes, ma'am.
Should we start?
Yeah, ma'am.
Yes,
Kuchel
ma'am.
Babu sir,
Yeah. Very good.
me, ma'am, and
Sir,
Kameshwara
Kameshwar,
sir,
sir.
to take over the discussion, sir.
Good evening, all the participants, and welcome the today's speaker, Dr. Indrani Hemant Kumar. Is well known to us since she conducted a national conference at Mumbai. She conducted very well at the time. We were the GC members, Kameshwar and myself. She is a leader. Not only she worked as a most of time in KEM Medical College, Mumbai, and is well known for her importance of anesthesiology teaching. She's all the students are there wide far away and they're doing, and they remember always her teachings. And is a past president of RSCP, and she attained all the positions of the ISA in Maharashtra, Mumbai, and at present is a GC member at National Headquarters ISA. And also she's well known as a Bharatanatyam. She awarded a Natya Kalamani and Bharat Jyothi Award. I know she will, all the postgraduates benefited with her today's topic, especially most important for the postgraduates, hypertensive disorders in pregnancy. It's very, very commonly come across for your postgraduate exams, especially in practicals. I hope we'll listen from her for learned madam. Thank you for accepting for this talk giving for the online madam. Thank you. Welcome. Dr. Kameswara, introduction few words.
Good evening, all. Thank you, Dr. Kucherbabu garu. And this, I first congratulate this city branch, Visakhapatnam, for regularly conducting this PG orientation and discussion series, which is really very beneficial and useful. And you are selecting the top national speakers for this, and which will be of very high usefulness for not only postgraduates but practicing anesthesiologists also. And another thing is this today's topic is so important. It comes as a theory paper question as well as short case, long case in the examination, and it is completely, totally a postgraduate oriented topic mainly. And the points in this are useful for the practicing anesthesiologists also. You have correctly selected the right speaker for this topic. And I appreciate Dr. Indrani for accepting our invitation. And thank you very much.
The state president, Dr. Durga Prasad, can you say a few words? Dr. Durga Prasad. You are in the line? You are there?
Yeah, sir.
Please.
Good evening, everyone. Sir, just I am attending because the topic is very interesting and the speaker is very well known. Just I am attending, that's all. Just a silent listener. Anyhow, I congratulate Vizag City Branch for doing this excellent program and month after month. And I wish them success and keep it going on. And thank you.
Thank you.
Good evening, sir.
Thank you, madam.
Thank you, sir.
Please present your presentation, madam. You can start your presentation.
Thank you so much, sir. Thank you, Dr. Praveen Kumar, Dr. Durga Prasad, Anuradha, and other members of Visakhapatnam ISA branch for giving me this platform to speak on such a critical topic in your pods series. I'm really very honored, more so because I have eminent people as chairpersons. What more can I ask for Dr. Kameshwar Rao, Dr. Kuchela Babu, who have been past presidents, who've been pillars of ISA National, and my dear friend Sri Lakshmi, who's a chairperson for this session. Thank you so much, sir. I'm really very, very honored to be part of this program. And friends, to all the postgraduates and to the practicing anesthesiologist, what I would like to say about this topic about hypertensive disorders of pregnancy is that it is a major contributor of maternal mortality. Right after obstetric hemorrhage, you find this as the major contributor of maternal mortality, and that makes this topic as much more important and vital for all anesthesiologists. And as Dr. Kameshwar Rao rightly said, that this is a postgraduate long case. So there is, so it's again a case where you can crack it, and you can, you can really, you can really, 1 minute, sorry. You can really score a lot of marks. And a topic which is, and also something which we see in our day-to-day lives. So let's straight away jump into this topic. I'm sure you're able to see my screen, isn't it?
Yes, ma'am.
Okay,
Yes,
madam.
ma'am. We are able.
Yeah.
Okay, let's start off with a case. It's a 35-year-old, a 34-weeker parturient. She comes with no significant past medical history. Her blood pressure when pregnancy was first confirmed was normal at 8 weeks. She is now admitted at 34 weeks with a mild frontal headache and an increasing swelling of her ankles, extending all the way up to the mid calf. Her blood pressure on admission is 170 by 100, and her urine dipstick test is showing 3 plus for proteins. What is the diagnosis? It's clear cut. It's a hypertensive disorder of pregnancy, and most likely it is preeclampsia. So, what are the hypertensive disorders of pregnancy? One is chronic hypertension. Next is preeclampsia, eclampsia. Preeclampsia superimposed on chronic hypertension. And the last is gestational hypertension, which is nothing but a transient hypertension of pregnancy or chronic hypertension in the latter half of pregnancy. So, your examiners are definitely going to ask you, what do you mean by chronic hypertension? What do you mean by gestational hypertension? What do you mean by preeclampsia? And what do you mean by eclampsia? So what is chronic hypertension? Chronic hypertension is nothing but a pre-existing hypertension before pregnancy. So it was present before the conception even occurred, right? So that is chronic hypertension. It occurs during the first half of pregnancy. It continues into the latter half of the pregnancy also. Gestational hypertension occurs after 20 weeks of gestation and returns to normal within 3 months of delivery with no other features of preeclampsia. So it is, if noted before 33 weeks of gestation, 40% of the risk run the risk of developing preeclampsia. So it is nothing but something similar to preeclampsia without the features of preeclampsia, which I will be coming to it now. So this is an update. So what is the definition of preeclampsia? For time immemorial, we used to say when the blood pressure is more than 140 by 90 and when there is proteinuria and, and when there is edema, that is when we call it as preeclampsia, isn't it? Now look at the latest definition of preeclampsia. It is by the International Society for the Study of Hypertension in Pregnancy. They define preeclampsia as a new onset hypertension, that is a systolic blood pressure more than 140 millimeters of mercury, diastolic blood pressure more than 90 millimeter of mercury or both, accompanied by, now listen carefully, the blood pressure, increase in blood pressure accompanied by even one or more of the following features. So what are the features? One is proteinuria of 1 plus or more, a PCR of more than 30 milligram per millimoles, albumin creatinine ratio of more than 8 milligram per millimole or both. So remember, preeclampsia can present without proteinuria. So it is no longer a diagnostic criterion. Remember that. So even if a high blood pressure comes with a renal derangement or a liver derangement or a neurological complication or a hematological or a uteroplacental dysfunction, it is still called preeclampsia. So there is no such thing as criterion that preeclampsia can be defined only when there is proteinuria. Remember that. But to all my postgraduate students, I would like to say this. You may have some examiners who may not have got updated on this issue. So you have to say that earlier, blood pressure of more than 140 by 90, along with proteinuria and edema, was a criterion for preeclampsia. However, with the International Society of Study of Hypertension and Pregnancy, the present definition is as follows. So it is hypertension of more than systolic blood pressure of 140 by 90, along with any one of the following criteria, one being proteinuria. Next is acute kidney injury, where the serum creatinine is elevated. Next is liver involvement, where there is elevated transaminases, increase in alanine transaminase, or where the limit is almost twice the normal range, or presence of neurological complications such as eclamptic seizures, severe headache, persistent visual scotomata, clonus, blindness, or an altered mental status, or a stroke. So all this will come to neurological complication. Hematological complications such as thrombocytopenia, a platelet count of less than 150,000, DIC, hemolysis, all this can be part of hematological complication. Uteroplacental dysfunction, where there is abnormal umbilical artery Doppler wave analysis, a restricted fetal growth, or a stillbirth. And finally, presence of edema is no longer considered a diagnostic criterion for preeclampsia. So, if preeclampsia is that, when will you call it as a severe preeclampsia? When the blood pressure is more than 160 by 110, which is measured twice, a proteinuria more than 500 milligram per day, which means there is a renal involvement and a reduced GFR, oliguria with urine output less than 400 ml over 24 hours, presence of thrombocytopenia where the blood count, where the platelet count is less than 1 lakh, impaired liver function, as I said, twice the upper limit, new onset headache, unresponsive to medication and not accounted by alternative, vomiting, visual disturbances, papilledema, clonus, presence of pulmonary edema or HELP syndrome, all of them will amount to severe preeclampsia. Now, these are some latest information which is now coming up with preeclampsia. So what is it? Now, even during the pregnancy, we have some risk predictions tools for early diagnosis so that we can have a better outcome with better treatment. So these are projected by the NICE guidelines, and they talk about plasma growth factor, which is PLGF. So what do they incorporate? All the placenta biomarkers. They incorporate uterine artery Doppler measurements and maternal risk factors to find out the risk of developing preeclampsia in these patients. So what do they do? First, they identify what is the plasma growth factor. What is the amount of plasma growth factor at before 35 weeks of gestation. If it is less than 12 picogram per ml, here is the parturient who can develop preeclampsia. And if it is at 34 weeks, if it is less than 12 picogram per ml, mind you, you have to prepare for her delivery within 14 days of testing. So plasma growth factor is a very important biomarker which peaks at around 26 to 30 weeks of gestation and reduces towards term. So this is a very important biomarker to understand whether the patient is getting severe preeclampsia. The other predicting tool, which is a soluble FMS-like tyrosine kinase 1, which is called SFLT1. So it is an antagonist. While plasma growth factor is a vasodilator, this SFLT1 is a powerful vasoconstrictor and causes endothelial damage. So when the good one is down, the bad one is up. So the bad SFLT is increased in preeclampsia. So It is found between 20 and 35 weeks of gestation. An increase in the risk of preeclampsia in women is found with high SFLT1 to P plasma growth factor ratio, and that can be done with the ELIXIS immunoassay to find out the increase in the ratio, right? So next one is the PrEP-S, that is prediction model for risk complication in early onset preeclampsia. It can be used up to 34 weeks of gestation. So what Fulpires, he validated the risk prediction models. And this need not be done only during 25 and 30 weeks of pregnancy. It can be done at any time during pregnancy. So what he did was, based on gestational age, vital signs and biochemical observations, so he predicted whether patient is susceptible to preeclampsia or not, and help in decision making as well as treatment, as well as to know whether the patient has to be admitted immediately to the hospital. So, what are the strong and moderate risk factors for the development of preeclampsia? The strong risk factor is when the patient probably had a prior preeclampsia or has chronic hypertension, a BMI of more than 30, pregestational diabetes, antiphospholipid syndrome, SLE, or patient has come with assisted reproduction. So all of them will contribute as a very significant risk factor for developing preeclampsia. So if that is preeclampsia, what is eclampsia? Eclampsia is the occurrence of seizures in a parturient that may have no underlying pathology. So the signs usually remit by 6 to 12 weeks postpartum. And how do you define? It is a generalized tonic-clonic seizures with or without raised blood pressure and proteinuria occurring during or after pregnancy with no other identifiable CNS etiology. So what could be the etiology of eclampsia? We will be looking into it. It is multifactorial. It could be because of vasoconstriction, ischemia, or vasogenic edema. So there is no reliable test for predicting development of eclampsia. The risk of seizure is more than around 1% in all the preeclampsia patients, and the period of highest risk could be antepartum and intrapartum periods, but about less than 40% can even occur in the postpartum period. Okay, so what is the pathogenesis? So again, this is again a very important question with a lot of people ask. So there were many theories about toxemia, immunological, genetic factors, reduction in nitric oxide, etc. But the one which signifies, which really can be acceptable, is of abnormal placentation. The abnormal trophoblast invasion at the time of placentation and a failure to convert the uteroplacental bed into a low resistance, low pressure, high flow system, where the ready response to intact musculoelastic portion of spiral arteries to vasomotor stimuli. So, as I said, there is increase in thromboxane, and which causes vasoconstriction and aggregation of platelets, and a decrease in prostacyclin, which causes vasodilatation and inhibit the platelet aggregation. So as I told you before, so there is vasodilatation, and the entire placental bed becomes a low resistance, low pressure, high flow system. So that's how it is. That's how the pathophysiology happens for preeclampsia. So what really happens at this point of time? There is an increase in vascular endothelial dysfunction, resulting in increase in coagulation and increased sensitivity to vasopressors. As I said, plasma growth factor is down, SFLT1 is very high, so there is increased expression of cytokines, angiotensin, catecholamines, and procoagulant factors. So what does it actually mean on the anatomical level? It means there is an increase in vascular tone, increased vascular permeability, there could be coagulopathy, ischemia of target organs like brain, liver, kidney, placenta, etc. And there is reversal of ratio of prostacyclin and thromboxane ratio, as I told you. So that leading to vasospasm, endothelial injury, platelet activation, and consumption. So what happens with all this? The widespread endothelial dysfunction may manifest in a pregnant woman as a dysfunction of multi-organ systems, including the central nervous system, the respiratory system, renal, hematological systems. The endothelial damage can lead to pathological capillary leak that can manifest in the mother as rapid weight gain, non-dependent edema on the face and on the hands, pulmonary edema, or even hemoconcentration. So when the placenta is diseased, it can affect the fetus via decrease in the uteroplacental blood flow. The decrease in perfusion can manifest clinically as non-reassuring fetal heart rate testing, low scores of biophysical profile, oligohydramnios, as well as fetal growth restriction in these patients. So let us look at it one by one. So the proposed source of inflammation, as I told you, is the placenta. So what happens with generalized vasospasm and a reduced intravascular volume? There is placental insufficiency, and that itself can incite diffuse placental thrombosis, inflammatory decidual vasculopathy, and trophoblastic invasion of the endometrium. And because of the hypertension, the diastolic pressure being more than 110, what happens? You can have placental abruption, fetal growth restriction, and premature delivery, and all of them leading to intrauterine fetal death because of poor placental perfusion, because of the increased resistance in the spiral arteries, and reduced fetal growth associated with oligohydramnias. So what happens in the cardiorespiratory system? As I said, there is hypovolemia, increase in systemic vascular resistance, left ventricular hypertrophy, and there is increased sensitivity to catecholamines, sympathomimetics, and oxytocin. Hypertension, there is labile hypertension. So with altered circadian rhythm, so this hypertension can push the parturient to congestive cardiac failure. There is increase in capillary permeability that can push the patient to pulmonary edema and ARDS. And the total increased body water can give rise to airway mucosal edema and tongue edema, which is classically seen in very severe preeclampsia. So what is the cause of pulmonary edema and severe preeclampsia? By and large, if they ask you this question, you have to say the most common cause is a non-cardiogenic cause, which is due to increase in cardiac permeability, a decrease in colloid osmotic pressure, or it could be because of overload, or it can also be due to cardiogenic pulmonary edema, as I said, because of impaired LV systolic or diastolic dysfunction. So when the patient does come with pulmonary edema, remember, you have to step up your monitoring and you have to treat the pulmonary edema with diuretics, etc. So, and also and with the invasive monitoring, you have to monitor the trends in the invasive monitoring. Coming to hematological issues with preeclampsia, what can happen? There could be a prolonged bleeding time. There is platelet dysfunction, I already told you, thrombocytopenia, I already told you, and DIC due to microvascular endothelial injury. So there is an autoimmune mechanism of platelet destruction. That is why there is so much of thrombocytopenia in these patients. There is increased level of platelet-specific immunoglobulins. And remember, the platelet dysfunction is directly proportional to the severity of the disease. All right. So you have to do the entire coagulation profile, PT, PTT, fibrinogen, etc. All this will deteriorate in DIC in these patients. What happens with the kidneys? Remember, the kidney is the first organ to get affected. in preeclampsia. There is a glomerular as well as tubular dysfunction. There is a decrease in renal blood flow, decreased GFR, proteinuria, increased BUN and creatinine. The proteinuria reflects an ischemic insult in the glomerulus, and the renal tubular function deteriorates relatively early in preeclampsia. So the patients develop oliguria and ARF, severe ARF. So here, what you need to understand in the presence of proteinuria or oliguria, you have to know that you have to balance your preload, because even a small amount of fluid can push the patient to pulmonary edema. What happens to the liver? There is abnormal LFT, as I told you, SGOT, SGPT, LDH, and there is low albumin. And epigastric pain is a symptom of tension on the capsule of the liver, which is caused by edema or intrahepatic hemorrhage. And presence of hepatic hemorrhage is associated with very high mortality. HELP syndrome, which is hemolysis, elevated liver enzymes and low platelets, is a very well recognized association with severe preeclampsia. What happens with the central nervous system? There is cerebral vasospasm, which leads to ischemia. And when there is an ischemia, you will have a disrupted blood-brain barrier. There could be cerebral edema, cerebral hemorrhage, all this present in the form of severe and persistent headache, which could be in the frontal, it's a migraine-like headache, blurred vision, photophobia, irritability, transient mental changes. All of them are reflecting warning signals towards the development of eclampsia. So patient can even be having coma. So there could be cortical blindness. That also can happen with cerebral vasospasm. So what are the investigation you have to ask for? One, of course, there is proteinuria. So there is urine output, 24 hours urine collection you have to do. You have to do a dipstick to know what is the level of proteinuria. Urine PCR you have to do. Entire blood workup you have to do. Urea, electrolytes, coagulation profile, liver, renal function test, serum magnesium, serum calcium, grouping, cross-matching. And for the fetus, you have to do a CTG, cardiotachograph, ultrasound scan to assess the fetal growth, amniotic fluid volume, uterine artery Doppler blood flow is very important to assess the placental blood flow. So what is our treatment goals? Our main treatment goal is now to control the CNS irritability and prevent the convulsion. And what does that? Which drug? Magnesium sulfate is that drug which is an anticonvulsant, and it reduces the irritability of the neuromuscular junction. The next important goal is to restore the intravascular volume, because the patient is chronically vasoconstricted. So a strict monitoring of the urine output, CVP to maintain at around 4 to 6 centimeters of water. You have to normalize the blood pressure. So for normalizing the blood pressure, we use antihypertensives which are safe in pregnancy, like labetalol, hydralazine, nifedipine, alpha-methyl dopa, etc. And magnesium itself has got a direct vasodilating action on the smooth muscles of the arteries and the uterus. And next important goal is to correct the coagulation abnormalities. So that, depending upon your coagulation profile, you may have to give platelets, FFP, cryos, etc. And the last goal is a decision regarding the timely delivery. So that depends upon the gestational age, fetal lung maturity, and the severity of the disease. So how do you prevent? There are studies which have been done. One important study is the ASPRE trial, where low-dose aspirin, 100 to 150 milligram per day, was started preferably before 16 weeks of gestation. And what they found was there was a mild decrease in the incidence of of preeclampsia in these parturins. The other famous study is the CLASP study. It's a very big study, and where they gave 60 milligram of aspirin as prophylaxis, as a targeted therapy, because we said thromboxane is increasing. So to reduce the thromboxane production, you give aspirin. So what did they find? They found that there was only a small reduction in occurrence of PIH and small reduction in preterm deliveries. There is no difference in the neonatal outcome in the CLASP study. Next was giving calcium, 1 gram per day. What did they say? Calcium, it's a CAP trial, calcium and preeclampsia trial. So they said that the exercise, there is, what do you call? It's again, it was not very conclusive that it helps in preeclampsia. So what the ACOG program guideline said was, for prevention, you have to do mild exercises that leads to less weight gain and macrosomia. So, and again, there was another study saying that should we give folic acid? That is the FACT trial. That is folic acid supplementation in pregnancy on preeclampsia trial. It's a FACT trial. So high dose folic acid supplementation, that is 4 milligram per day beyond the first trimester, does not prevent preeclampsia. So this was all the inference of all these famous trials in preeclampsia. So coming to the treatment. So the drug treatment is recommended whenever the blood pressure is more than 140/90. Remember, all that we are doing is to only reduce the myocardial and the cerebrovascular complication. But this, whatever treatment we are giving, the CHIPS trial, which says that control of hypertension in pregnancy study does not alter the course of PIH or the fetal well-being. So let me continue with the same case. She is reviewed by a junior obstetrician, and the multipara monitors are attached for continuous vital monitoring. A continuous CTG monitoring is also commenced. We have started a 16 gauge, say, IV cannula, and above bloods are sent for laboratory. So what are the goal and the initial treatment? The goal is to get the blood pressure down. That is the first goal we want to do. So here, the thing is, if the BP is 170, 180, etc., we have to rapidly get the BP down to around 150 immediately. Okay? And over a period, bring it down slowly to around 140/90. So that should be the goal. Okay? And how do you achieve that? You can achieve that with the use of antihypertensives. So again, as I said, we want to avoid antihypertensives is only to avoid complications arising from preeclampsia, such as cardiac failure, myocardial infarction, placental abruption, all that which I told you, right? So diuretics are completely avoided because they prevent the physiological volume expansion which is seen in normal pregnancy. So you have to avoid diuretics at all cost. Methyl dopa is again has got very few side effects. It's centrally acting and it has got very few side effects, and about 250 milligram BD or TDS has been recommended. But the one which is acceptable in modern days is the use of combined alpha and beta blocker, that is labetalol, which is again, or you can use metoprolol or oxprenolol as you know, for treatment. So they are not associated. Why they are used? Because they are not associated with fetal growth restriction, and the dose will be around how much? Around 100 milligram IV or not more than 2,400 milligram per day. So nifedipine, calcium channel blockers can also be given, but remember, you should never give it sublingual. Always give it around orally 10 to 20 milligram every 30 minutes to control the blood pressure. And sometimes you can have a sudden fall in blood pressure, remember, with calcium channel blockers. So it can give rise to maternal hypotension and fetal distress. And it also can give rise to, and it can interact with magnesium sulfate, giving rise to profound muscle weakness also. So, but then you use it as a backup, not as a frontline treatment. Prazosin again is a second line, hydralazine a second line treatment. Hydralazine is both an arterial as well as a venodilator, and it can be used for when the patient, and it can cause hypotension in the mother and eventual fetal distress because of that. And what about alpha adrenergic inhibitors, which can be used only for chronic hypertension patients because you need diuretics for the salt and water retention which it produces. What about ACE inhibitors? ACE inhibitors and angiotensin II blockers are avoided completely. This is again a question which can be asked because it is associated with oligohydramnios, stillbirth, and neonatal renal failure. So you should never use ACE inhibitors and angiotensin II blockers for controlling the hypertension. So BP is not controlled with oral hypertensives now. Now the patient complains that her headache is worsening and she's seeing flashes of lights. She's found to be hyperreflexic and she's given a dose of oral labetalol 200 milligram. At this stage, her BP is being monitored every 15 minutes, and despite the oral antihypertensives, her BP remains very high at 170 by 120. Now, even after an hour, even after giving labetalol, now what needs to be done? What should be done when the BP is not coming under control? You have to switch to intravenous labetalol. But before switching to intravenous labetalol, remember, because there could be a sudden fall in blood pressure, you have to give a small fluid bolus of about 250 ml before giving the bolus of IV labetalol. That has to be given 20 to 40 milligram every 15 minutes to a maximum of 220 milligram per hour. You can even give it in the form of an infusion. Okay, what is the contraindication? The contraindication is presence of bronchial asthma. Never go more than 2,400 milligram per day. So if the BP is not getting controlled, even with maximum injection labetalol, what are your backup? I told you all the second line drugs like hydralazine. You have to give 5 milligram very slowly. Remember, it is both arterial and venodilator. So the blood pressure can crash suddenly. Check the blood pressure every now and then. Simultaneously, at this point of time, when the BP is not getting controlled, think that right now whether I should start magnesium therapy in addition. Especially if there is going to be a progressive CNS symptom. Mind you, this patient has come with headache. So now is this the time? Because the BP is not coming down. Now probably is the time to start magnesium in this patient. Okay. So what about magnesium? Magnesium, dear students, remember preeclampsia, never forget magnesium. It is used as a prophylaxis for severe preeclampsia and as treatment of eclampsia. In low resource area, it should be used whenever there is even more, just 2 features, or even if it is a mild organ dysfunction, you still should start magnesium in these patients in low resource area. We don't want the patient to deteriorate. So you have to start early. Okay. And dose is again, this is again a question you asked in all your exams. What is the loading dose? Loading dose of 4 to 6 grams, followed by an infusion of 1 to 4 grams per hour with a goal to achieve a serum concentration of 5 to 8 milligram per deciliter up to 24 hours following delivery or 24 hours after the last seizure, whichever is later, unless there is a clinical reason to continue. So this is again an update. So if for 12 hours postpartum, patient is stable with no seizure, you can stop the Maxsulf infusion in those stable patients. So what do you monitor when you give magnesium? you have to monitor urine output, deep tendon reflexes, respiratory rate, oxygen saturation, and serum concentration is done as long as magnesium sulfate is continued to avoid toxicity. So what are the side effects? Side effects are headache, nausea, vomiting, flushing, and weakness. And the toxicity, how do you determine the toxicity? There is suppression of the deep tendon reflexes. Patient can become drowsy. There could be respiratory depression and cardiovascular collapse. And how do you treat a toxicity, magnesium sulfate toxicity? You have to treat it by giving IV calcium gluconate for these patients. So what are the anesthetic implications of giving magnesium sulfate? Remember, it has got vasodilative property and it may improve cerebral ischemia and uteroplacental blood flow. It has got a mild to moderate hypertensive effect. It decreases the uterine tone, increasing the risk of postpartum bleeding. Remember, a patient of preeclamptic toxemia can develop postpartum hemorrhage because when the patient is on magnesium. Augments neuromuscular blockade by inhibition of calcium-mediated presynaptic release of neurotransmitters. We know that. So if you have given vicuronium, then the effect of the vicuronium will be for a longer time. Magnesium also has analgesic effects, and the neonatal effects may include hypotonia and respiratory depression. So what are the alternatives if you can't give magnesium? Then the other alternatives are if the patient has renal failure or a toxicity to magnesium, then you can give IV phenytoin or you can give injection levetiracetam to the patient. When will you give steroids? Steroids are given whenever you find the patient is having a HELP syndrome because steroids help in minimizing the endothelial damage which happens with them. So there is a decrease in the damage to the hepatocytes and platelet consumption. So glucocorticoids, when used 24 to 48 hours before delivery, it improves the fetal lung maturity and increases the maternal platelet count before delivery, thus making regional anesthesia very safe. Dexamethasone can be given as 10 milligram every 6 hours for 2 doses, followed by 6 milligram every 6 hours for 2 doses. So you can give this or you can give even betamethasone 12 milligram IM for 2 doses. So this will definitely improve the fetal lung maturity and increase the maternal platelet count. Okay, so let us continue with the patient. So a bolus dose of labetalol is given, followed by continued infusion, and her BP starts to stabilize. Her diastolic falls to 90. Now we have given ringalactate to that patient, and her urine output is more than 100 ml in 4 hours. So you can remember that if there is excessive administration of fluid, what can happen? You can have pulmonary edema and other problems, right? So here you have to restrict the fluid to 100 ml per hour. So observations of blood pressure, oxygen saturation, heart rate, respiratory rate are performed every 15 minutes along with continuous CTG monitoring. Now the obstetrician is planning delivery for her, and at that point of time, she has a grand mal fit. Now, how will you manage? Remember, students, don't say I will give IV midazolam. Don't say that. The drug of choice, which you have to say, is and will be only magnesium sulfate and magnesium sulfate. So what is a fit? Fit is an eclamptic seizure. You can have other causes. Remember, it has to be non-CNS cause that is related to the pregnancy. Only then it is called eclampsia. So other minor causes could be, presence of epilepsy or an intracranial event like subarachnoid hemorrhage or a CVA or a vasovagal or hypoglycemia. All these also can constitute a seizure in the patient. So you have to check the blood sugar in this patient at the point of time after you have controlled the seizure. So what will you do? How will you manage an eclamptic seizure? Immediately turn the patient to the left lateral position, call for help, do your ABCs, give high flow oxygen by face mask, obtain an IV access, start IV magnesium immediately. Monitor ECG, blood pressure, respiratory rate, oxygen saturation, and I said check the blood sugar. So remember, even NICE guidelines do not recommend the use of benzodiazepines or any other anticonvulsant as an alternative to magnesium sulfate. Only if magnesium sulfate has failed and the patient is repeatedly getting eclamptic seizure, or if the patient has got renal failure, turn on to the other other anti-eclamptic medications, as I already told you. Now, a bolus dose of magnesium is administered and she is commenced on an infusion of 1 gram per hour. Her respiratory rate and reflexes are checked regularly. She is placed on the left lateral position. Now, what are the delivery management decisions? Now that her eclampsia is controlled, can we go for a vaginal delivery? Or should we induce the delivery? Or should we go for a cesarean delivery? You have to make a decision on that. If the patient is stable on antihypertensive medication and with acceptable lab values and reassuring fetal tests, okay, so you can go for a vaginal delivery, okay, with close monitoring of the patient, both mother and the child. Delivery can be induced when the fetus is more than 37 weeks of gestational age, when there is lung maturity, a favorable cervix, or if maternal or fetal deterioration occurs despite your conservative management. In all other cases, whenever there is extreme prematurity or fetal compromise, you need to go for a cesarean delivery. What are the indicators for an immediate delivery, immediate cesarean delivery? Severe hypertension that persists for more than 48 hours, progressive thrombocytopenia, liver dysfunction, progressive renal dysfunction with oliguria, premonitory signs of eclampsia, and evidence of fetal jeopardy. In all this, you have to push the patient for an immediate cesarean section. Coming to how do you manage a HELP syndrome? HELP syndrome can only be managed with supportive management, seizure prophylaxis, blood pressure control. So you try to, with all the drugs which I told you, and immediate delivery if the patient is near term. In the meanwhile, you have to give blood products, give corticosteroid for fetal lung maturation and increasing your platelets, plasmapheresis if it is refractory, and close surveillance of the mother for at least 48 hours after delivery. So blood and blood products are the crux of treatment at this point of time. There is thrombocytopenia and there is coagulation derangement. So platelet transfusion is given in all patients with HELP syndrome whose platelet is less than 20,000 per cubic millimeter, or in the presence of significant bleeding from punctured sites, wounds, or ecchymosis. About 6 to 10 units of platelets should be given before intubating the patient for cesarean when the platelet count is so low. Remember, it is an ongoing fall in platelets. Red cells and FFP may also be needed in patients with severe coagulopathies. Fluid restriction. Remember, with all these, blood and blood products transfusion, you can end up with fluid overload. Circulatory overload is common and the patient can be pushed into pulmonary edema. Remember that. So that is very important. And you have to do fluid restriction in these patients. The CTG now demonstrates repetitive and severe fetal heart rate deceleration. She is reviewed by the senior obstetrician and a decision is made for an emergency delivery by cesarean, which is a category 1 section. The anesthetist attends to make a plan for anesthesia. Now the patient is pushed into the emergency table and you have been called for anesthesia. Now, what is the most appropriate anesthesia technique? Will you give GA or will you give regional? If the coagulation is normal, regional anesthesia is encouraged, even in high-risk patients. Remember that. So what are the concerns? The concerns are the derangement of coagulation and increase in ICT. These are the deterrents if you're giving regional anesthesia. What are the deterrents if you're considering general anesthesia? You can have a very difficult airway. There is a lot of edema, airway edema. There could be aspiration, the problem of having magnesium sulfate, having given magnesium sulfate, and all the problems which can add to the, add to the issues because you're giving drugs also other drugs for general anesthesia which can interact with magnesium sulfate. So all these are problems, and of course pain management during labor. So the regional anesthesia is, again, as I already told you, if the coagulations are normal and if the patient doesn't have raised ICT, then single shot spinal or giving it along with epidural is safe. Remember, because it provides a rapid, dense, and predictable block, and it avoids all the complications attributed to general anesthesia, like exacerbated hypertension during induction and extubation, drug interactions, aspiration, maternal awareness, failed intubation. All these can be avoided by giving a regional block, a regional anesthesia. So if you are, so what are the things you will evaluate in the preoperative? So remember, all of them are important. One is to know how severe is the preeclampsia and how much the patient has been optimized. Then you evaluate the upper airway and the lungs, whether there is any edema, whether there is any stridor, whether there is any change in voice, whether the patient is having dyspnea. All this can be, indicators of pulmonary edema, also underlying pulmonary edema. And then you also have to assess the volume status. So if is there any change in the urine output? What is the coagulation status of this patient? And what are the medication? Is the patient on a magnesium sulfate infusion? And if the patient is on magnesium sulfate, remember you have to keep on repeating the coagulation profile every 6 hours. And also you have to know how much is the platelet count, whether there is any DIC, because you don't want to end up with epidural hematoma and spinal cord compression, isn't it? And in the presence of HELP syndrome, will you go for a regional anesthesia? Well, if the platelet count is normal, more than 75,000, usually safe to receive regional anesthesia. You can use a small needle, okay, small spinal needle, 27 gauge you can use, or you can use a Whittaker needle. You can use that safely, okay. And in presence of, and if it is less than 75,000, okay, you have to weigh out the risk of general anesthesia versus regional anesthesia. So if you already know there is a predictable difficult airway, okay, or regional anesthesia may be considered after platelet transfusion prior to the procedure. Okay, so in that case, you also have to do platelet function by doing a TEG. Usually, a TEG and aggregometry or flow cytometry is very, very conclusive to tell you whether the platelet function is good. But of course, many of our hospitals do not have, and we try to look at bleeding time, friends, but bleeding time is not the right test to know the platelet function. Remember that. It's no longer considered useful for epidural placement, and definitely it does not necessarily reflect the risk of bleeding at other locations. TEG is a very, very reliable test. You can use that. And again, it will not tell you whether patient can have epidural hematoma, but considering all, the PFA 100 and aggregometry is the best test for platelet function. So, but that is beyond, it only probably happens in very big hospitals or abroad, not in India. So, what about labor pain relief? Well, it is the best form of pain relief, and it should be instituted early in labor. If the patient is nicely under control, blood pressure is nicely under control, it also controls the blood pressure because the hypertensive response to pain is attenuated by epidural analgesia. It eliminates the need for opiate analgesia. It reduces the circulating level of catecholamines and stress hormones and aids the BP control. It increases the uteroplacental and intervillous blood flow, relieving the ischemia, which is underlying pathophysiology here. And it facilitates the subsequent administration of epidural anesthesia if the patient suddenly comes for an emergency section or forceps or vacuum extraction, etc. So you have to ensure, as I said, all the coagulation parameters. If epidural cannot be given because of deranged coagulation, today we have an excellent drug in remifentanil that can be given as a PCA to produce labor analgesia. Again, ropivacaine is better than bupivacaine. And remember, Should hypotension occurs, you have to give a fluid bolus and adopt a full lateral position by the patient. Okay, so all this should be kept in mind when you're giving labor epidural analgesia. You have to, apart from your standard monitoring, you have to step up your monitoring, especially in when very high, severe preeclampsia cases. You can start a CVP line and an arterial line. And in those institutes which has non-invasive cardiac out, go ahead and start, using that also. All this has to be done. What about general anesthesia? The administration of general anesthesia to a preeclamptic parturient is one of the most challenging moments to an obstetric anesthetist. The difficulties which they face will include potential difficult intubation, accompanying the mucosal swelling of the pharynx, which may interfere with the visualization of the larynx. Then also it could be because you can have an exaggerated response to intubation and extubation, and also the need to maximize the oxygen delivery to the mother and to the fetus. Okay, all these are very challenging to give general anesthesia. So, general anesthesia is preferred in cases of suspected placental abruption, coagulopathy, severe pulmonary edema, eclampsia, wherever you cannot give regional, that's as a last resort we will give general anesthesia. So hypertension, again, as I said, during induction, extubation, emergence, and loss of airway due to pharyngeolaryngeal edema, aspiration, all these are the problems. Remember to keep small tubes starting from 5.5 number, and a variety of laryngoscope and other aids to secure your airway. Difficult airway thing has to be ready. Your trolley should be ready. Drug used to attenuate the hypertensive response should be ready. You have to keep magnesium, labetalol, nitrates, lignocaine, xylocard. All of them have to be kept ready because you want to avoid intracranial hemorrhage or myocardial infarction in these patients. So whenever you're giving general anesthesia, remember facilities for neonatal resuscitation should be available because the mother has been on magnesium. And if you have given opiates, then you have again a big problem with the neonate. So the neonate has to be assisted with ventilation. Neonate may also be resuscitated. In these patients, again, remember these patients can have postpartum hemorrhage, especially because you're using isoflurane or sevoflurane. It causes vasodilatation and you can end up with an hemorrhage. You have to be prepared with treatment for a postpartum hemorrhage, and consider, as I said, the neuromuscular blocking will be prolonged because of interaction of magnesium with, or calcium channel blocker with the neuromuscular blocker. Avoid ergometrin in all forms. You have to give oxytocin, but give about 2 to 3 international units as a bolus over 1 to 2 minutes. And then the remaining, you can give about the remaining 7 units or 10 units, you can give over an infusion slowly. Okay, you can go up to 20 international units. If there is bleeding, then you can step it up to even 40 international units. Okay, patients, but remember, don't give methogen in these patients, as I said, because there will be a sudden rise in blood pressure in these patients. Patient have to be extubated after the full return of consciousness and airway protective reflex. Now she's transferred to the theater in the left lateral position. We have given RSI, we intubated, blood pressure suddenly went up. Okay, and then which settles down, delivery is done. We've given fentanyl, anesthesia, and uneventful. At the end of the cesarean section, she is slow to wake up. She's not waking up now. Why? The delayed awakening could be because of excessive anesthetic agent or excessive opiates, inadequate reversal of neuromuscular blockade. As I said, magnesium potentiates the neuromuscular blocking agent. Respiratory depression because of magnesium toxicity, hypoglycemia. And finally, you have to rule out an intracranial event in these patients. And how will you find out? Look at the pupils. If the pupils are constricted, fine. They should be diagnosed by pupil examination and response. An emergency CT scan has to be done in these patients. Fortunately, she wakes up after 30 minutes and makes an uneventful recovery following the general anesthetic. Now, what will you do? She has woken up. Now she is fine. Now, what will you do? Will you send her to the ward? No. She has to go to the ICU. ICU monitoring should continue to 48 to 72 hours because, as I said, 40 to 70% of the convulsion can be repeated even in the ICU. Pulmonary complications, because there is autotransfusion, pulmonary edema can occur in the postoperative period. Patient has to be monitored. Laryngeal edema may worsen even in the postoperative period and may require reintubation. Antihypertensive therapy is continued till clinically indicated and anticonvulsant medication maintained till the patient remains asymptomatic, and avoid fluid overload and maintain a urine output, give adequate pain relief in the postoperative period. So, preeclampsia poses a clinical challenge requiring considerable skill and experience on the part of anesthetist, and a vigilance and prompt action leads to better outcome. Thank you very much.
Thank you, madam. Excellent presentation, madam. You covered from basic to pathophysiology, what are the common causes, and also how to optimize. This is most important, how to optimize the patient preoperatively and how to assess the patient going to preeclampsia to eclampsia, and how to optimize the patient by hypertension, especially for an anesthesiologist before taking up the cesarean. And what are the difference between when should take a patient for a spinal and when should take the general? What are the contraindication for the general anesthesia? Excellent presentation, madam. I think there's no doubt should be there for the postgraduates. You covered, given all what are, suppose they'll have most of the time they have many doubts. When should we do a patient with a spinal? Whether only hematological, other complication, especially platelet HELP syndrome also you covered in the, even though HELP syndrome with the liver with dysfunction, with the platelet count is more than 75,000.
Yes.
That's excellent question. There's nothing to any doubt about the for PII with this presentation. They are maybe well versed. They can for any, especially in exams. They can, especially exams point of also you given a very good. Thank you very much. I think that my other moderators, Kamesh Ragar, Sri Lakshmi can extend anything.
Very nice, madam. As Dr. Kucharbogar said, he covered every aspect. I think there are no doubts for any postgraduate because what are the possible examination questions and what they have to answer also, you have crystal clear covered every aspect from pathophysiology to complete clinical management. Very nice talk, madam.
Thank you so much, sir. Thank you so much. Coming from both of you, I mean, it's a very big thing for me. It means a lot.
Thank you, madam.
Sri Lakshmi, are you there?
Sri Lakshmi?
He had some net problem.
Yeah, the Sri Lakshmi is not there. Madam, the chat box, few questions are there. You can see, otherwise I'll ask you.
I'll just see, sir.
There's a few questions. I think one thing is what is the severe preeclampsia features. Already you have a slide. I think they missed that slide. They're asking, and especially what about the dexamethasone? Can you use? I think this is for a sedation. I think what they want it. Dexamethasone in a preeclampsia, eclampsia. She did mention.
Dexmedetomidine for what?
Most probably it may be maybe post-operative pain management. I don't know what she wanted.
Dr. Naresh Paliwal, do you want to unmute yourself and ask specifically at what stage you want to give dexmedetomidine?
Naresh Paliwal.
Dr. Naresh Paliwal is my very good friend from Amravati, and he is very well known for.
Okay. Most probably you'll use in a dexamethasone the patient on the post-operative ventilator or something like sedation will use it, not for any hypertension control or nothing. Huh?
Dexmedetomidine is a all-in-one drug. So my question was whether it can be used as an antihypertensive, sedative, analgesic, because we have used in few patients to control when we want to control the hypertension,
No,
especially on
sir.
table.
The blood pressures are really very high during preeclampsia.
Yeah,
And dexmedetomidine is not the choice for
there are few references,
antihypertensive.
recent this thing.
So it is not the choice, I
It
said.
has a
It is
better.
not
No,
the
it's not a choice because it
And
there are no publications.
dexmedetomidine doesn't cause so much of fall in blood pressure as much as it causes a fall in heart rate. So
No,
it is not
we
such a
have used
good drug for blood pressure.
because it has some other properties. It is only apart from amnesia, it has all the properties.
Yes.
So
Yeah,
during
analgesic property,
anesthesia,
especially sedation analgesic.
It is not at all a very good drug. It's not a frontline drug. So
no,
the
it's not a one-time drug, but when other things are not available, or if you want to give because it has a high placental retention, so it does not cause any fetal bradycardia or distress. So it has been said to be a better drug.
No, but
because
it
the
may
high
not be
placental
useful. That's what
retention.
I'm trying to say. It may not be very
There are
useful.
few publications in recent times about use of dexmedetomidine in PIH.
So I don't think it has
Maybe
come
few
to the
studies,
nice
maybe there
guidelines
should
or
not have
the
first-line drug.
presentation.
it is not
Sir, maybe paper
It's not a
presentations are
frontline drug
not all
because it is not yet
acceptable.
come into the
yes,
routine
it has not
practice.
come into the guidelines at all.
Routine
Not
practice, but there are few publications which, and we have
Publication
also
paper
used it.
presentations are more, but it should be a guideline.
Yeah, it should be in the guidelines, but that's why I asked a question.
Yeah.
Yes,
Okay,
sir.
thank you.
Yes,
Thank you very
that's
much.
what I
Thank
said.
you very much, sir. One more
Recent
question
times
is
there
there.
are publications.
Okay, thank you.
Thank
One
you.
more question. Levoleuclar is contraindicated in bronchial asthma patient. What should be the first line of drug choice especially in a eclampsia or a pre-eclampsia patient?
So
What her doubt
if
is
the
about
patient is having bronchial asthma, you can always give nifedipine. You can give calcium channel blockers.
Yeah. No. Even Levoleuclar is also absolute contraindication is not there. It is a beta agonist. It is right. Sometimes beta blocker, but not that much of. But if it is, you can known case of severe asthma. Known case severe asthma, definitely it should be contraindicated. You can go for madam already cleared. What are other drugs?
Blockers you can get.
Okay. One more question is about the IV magnesium sulfate stops seizures immediately, madam.
Yeah, you have to give IV magnesium. That's why I said magnesium.
Yeah. The drug of choice and
You have to give magnesium only.
Yeah.
Remember, if you don't mention magnesium in your exam, you will, I don't know what, at least I will not.
Sandeep Syed.
Good evening, Dr. Sandeep Sajjani, HOD Anesthesia District Hospital, Bijapur, ma'am, Karnataka.
Namaskara, sir.
Namaskar, ma'am. Ma'am, why I asked about magnesium is most of the preeclampsia patients, they are already on magnesium. If they throw seizure at the table, on the table, then what is left? Do we need to repeat the magnesium or should we go for second line benzodiazepine?
Sir, if the patient is throwing a seizure,
yes, ma'am.
Spite of patient being on magnesium, you can give levocetam.
Yeah, that's what I wanted to ask. Like benzodiazepine, you said it is not advisable.
Never talk about giving midazolam, because I have heard, as an examiner, I have heard, some students talking about giving midazolam. That should never be uttered.
Right. It is always magnesium sulfate that is there, but the patient who are already on magnesium, then the concern with benzodiazepine and giving at seizures during pregnancy is most of the time it is respiratory depression.
Yes.
If we are ready to tackle that, then how about using the benzodiazepine?
No. We have better drugs like phenytoin and levocetam. Why not give phenytoin and levocetam?
But as per the studies, there is no much change in the outcomes, rather whether it is maternal outcomes or the fetal outcome, the infant outcomes. Though there are little delay in the yes, ma'am.
We have to stop the fit first.
Yes, ma'am.
So for that,
So-
you have
my answer is magnesium can be escalated till the serum concentration reach more than 8 or some clinically, if the patient is clinically is not intubated, you can see the clinical response. They might take
Yes, sir.
10 or X other
And
difference.
but is it not taking risk with magnesium, sir?
Can increase the dose. So no
Yes, sir.
harm it unless you have a
you can
signs
give
of
a bolus,
toxicity.
yes.
Yeah. If the
Unless you have
patient
signs
is
of
already
toxicity, you can go on,
intubated, then we
increase
will
the
not be able to
magnesium.
check the reflex. And the urine output also we have to monitor afterwards. That will take the consequences will be delayed. So
Yes.
for analysis, it will not be immediate
First
availability
of
of
all,
the clinical
the
picture will be
conversion, sir.
little difficult. But with benzodiazepine, or rather we take it as a midazolam because most of us are like in our setup, in every setup, midazolam is now present because we don't use most of the time we don't use diazepam.
No, sir,
So
midazolam
initially,
should not be used, sir. Should not be
Ah,
used. Should not be used.
okay. But the objection for midazolam or any diazepam, benzodiazepine is
Obtundation. Obtundation.
is-
Patient is already obtunded, already having
uh-huh.
CNS effects.
Yes,
Okay,
ma'am.
so we don't want further obtundation in this patient.
But you can go for intubation and control the respiration, no, ma'am?
Yes.
Ah,
You can.
that can be
That's why I
done.
said
But
ABC. You have to check the ABC first.
yeah.
Good evening, madam.
The last question: what are the advantages of hydrolyzin over the labetalol?
Hydralazine is a very powerful antihypertensive. It has got both arterial as well as venous dilatation. So if your labetalol fails, if in spite of giving maximum amount of labetalol, the blood pressure does not come down, then the drug of choice, second drug of choice is hydralazine.
Good evening, madam.
This the questions in the chat box is over. If any questions are there, you can unmute and ask.
Sir,
Otherwise,
good evening, sir. Good evening, sir. This is Dr. Ramana Prasad. For the sake of postgraduates, I want to add something. The vasodilating action of magnesium sulfate is more on mesenteric vessels rather than cerebral vessels. That it acts on the GABA NMDA receptors. It inhibits and it stabilizes the blood-brain barrier and increases the seizure threshold.
So what happens with the magnesium? You're right, but the question is it causes vasodilatation, specifically in those areas of vasoconstriction in the brain. Okay, so that is why magnesium has to be used. And also, the outcomes are not going to change in preeclampsia. That is another important. I already said about that. The maternal and the fetal outcome is not going to change, but these are all just, for controlling the effect. That's all. We are not treating the pathophysiology, mind you. Pathophysiology is still there.
Madam, another question for postgraduates. What is the Mississippi classification of HELP syndrome?
What is it?
Mississippi classification of HELP syndrome. It is graded in 3 grades, depending on LDH and serum bilirubin.
Yeah, there is gross thrombocytopenia and there is raise in the hepatic enzymes, right?
And peripheral smear, schizocytes.
So all those are there. Yeah.
Thank you, madam.
Good evening, madam. Good evening, madam. This is Dr. Subramaniam, sir.
I will close because we are
Anantapur.
running short of time.
Yes, sir. Really a wonderful presentation, madam. We have covered almost all the aspects, especially for the postgraduates, because it's a very important topic for them, not only for clinical, but also for exam point of view. And if the uterus is not responding to oxytocin, we can also try for carbetocin, madam, one of the latest drugs.
You can.
There is no contraindication in PIH.
I would not say there is no contraindications because I'll tell you what happens with oxytocin or even carbetocin is the vessels are hyper responsive.
Yeah.
The blood vessels are very hyper responsive. So if you're giving it, you have to give oxytocin, but then give it slowly, give it in smaller, give it 3 units first, and then you follow it up as an infusion.
Infusion.
Carbetocin 100 you can give, but then you give it very slowly over 15 to 20 minutes.
Okay.
You can give. You can give.
Yeah.
See, you
In the
have
initial
to
stage,
give a
no
uterotonic
sodium, they'll give
because
a
remember you are
vaginal
giving
tablet.
magnesium. Magnesium causes uterus with the tone of the uterus is less. It brings down the tone of uterus, and because of that, it can cause postpartum hemorrhage. So you have to increase the tone of uterus. So that can be done with oxytocin and carbetocin. It can be done, but remember, because of the lability of the blood pressure, you have to give, but you give it slowly. That's all I'm saying.
And one more point, madam, regarding the choice of anesthesia in eclampsia. You said, of course, manual can also be given, but for the postgraduates, some examiners may not accept that, madam, because in eclampsia, we usually teach postgraduates as spinal is contraindicated. Some examiners may not accept that word, madam. From the postgraduate point of view, I'm telling.
Okay.
No,
See,
madam is told already eclampsia is already controlled. Patient
Of
is
course,
not
sir,
at all,
of
not
course.
patient
intubated,
is
nothing.
under
Patient
control.
is well controlled. Patient has seizures are well controlled. After that, only go and perspire. Otherwise, it will be general only. Dictum is general only.
But if,
Yeah.
in spite of eclampsia, if there is fetal distress following that, then you have to go for general anesthesia.
Yes.
But if the eclampsia is controlled and the patient is conscious, okay, not
Not
obtunded,
immediate, not a seizure. You not immediately
there is no
terminating.
depression. Patient is not obtunded. Patient is conscious. You can straight away go ahead and give regional. Regional is the choice.
Okay, ma'am.
But as you said, there is a caveat to it. Patient
Yeah.
has to be controlled for the eclampsia.
Okay, madam. Thank you.
Thank you, ma'am. We'll conclude the session, but the time
Yeah.
is lack of time. Thank you.
Thank you, Dr. Kuchel Babu. I am
Thank
Dr.
you, sir.
Ramchandra Reddy.
Oh, thank you. Thank you.
Yeah, I'm Dr. Kameswar Rao.
Sir. Happy to see
I
you.
am in
Classmate.
I am in New York, and I appreciate the lecture so much. I worked in a high-risk maternity hospital in Saudi Arabia for 4 years. I have seen all the presentation, what she has done. I have seen practically. I appreciate her lecture like anything. And
Very
I have
nice.
worked without a single mortality. And we used to get eclampsia and pre-eclampsia cases, at least 2 cases in a week.
Oh my
And
God.
we were only 4 anesthetists, and we used to manage so nicely. And the lecture is very, very good. And you have to read volumes of obstetric anesthesia books to get this knowledge.
Thank you so much.
Okay,
And
thank
we
you.
have
Thank you.
not given regional
Thank you,
for
madam.
anybody. Almost all the cases were done under general anesthesia.
Oh my God. Oh, nice.
It was 2 decades back. I stopped working.
Oh my. Okay.
It is between 2000 to 2004, madam.
Oh, wow.
Praveen, you can start
Okay.
the session. Thank you. Thank you,
Thank you, ma'am.
everyone. Your contribution.
madam.
Yeah.
Thank you, ma'am.
Thank you,
Thank you,
Ramchandra.
ma'am.
Thank you.
Thank you,
Yeah.
ma'am, for delivering
Thank you.
the lecture in such a clear and lucid way. It was very much useful for the postgraduates, and we would be grateful if you could continue your academic support for our city branch. We are sincerely grateful to our esteemed moderators for today, Dr. Kameshwara sir and Kuchel Babu sir and Sri Lakshmi madam, for conducting the session so smoothly with their guidance and experience. Thank you very much, ma'am. So we'll be moving on
Thank
to
you,
the
madam.
next session.
Thank you.
Next session for today, a case presentation on anesthetic considerations in an obese patient posted for lap cholecystectomy by Dr. Amala Jyothi, postgraduate from GMC Srikakulam. The examiners and the moderators for this case are Dr. Subbalakshmi Madam, Professor and Head of the Department, GMC Srikakulam, Dr. Jaidir Babu Sir, Professor and Head of the Department, GMC Vijayanagaram, Dr. Manjula Ramsali Madam, Head of the Department Anesthesia, Seven Hills Hospital. Over to the examiners.
Thank you very much. I think Dr. Amala, who is the postgraduate from GMC Srikakulam, can start the case presentation.
Yes, ma'am. Good evening, all the faculty members and respected seniors and juniors. Today, the topic of discussion is about anesthetic considerations in an obese patient posted for lab cholecystectomy. So my patient is a 42-year-old female patient, Y Kalpana, housewife by occupation and resident of Srikakulam, who belongs to low middle socioeconomic status and non-Vaishyas community, came to the hospital with a chief complaint of pain in right upper part of abdomen and vomiting since 3 days. History of present illness. Patient was apparently all right 4 days back and having right upper abdominal pain since 3 days. Insidious onset, aggravating after taking heavy meals and relieving on fasting with medications. Patient has history of vomiting since 3 days, non-bilious, non-projectile in nature, aggravating after food intake and relieving on fasting. No history of fever, palpitation, and shortness of breath. Past history. She was diagnosed with obstructive sleep apnea 2 years back, and she is on CPAP therapy during night time. And there is no history of other comorbidities like hypertension, diabetes mellitus, asthma, ischemic heart disease, thyroid disorder, tuberculosis, epilepsy. And menstrual history, menstrual cycles are irregular and with reduced bleeding. Past surgical history. There are no previous surgeries under anesthesia. Coming to personal history, appetite normal, sleep disturbed due to the obstructive sleep apnea, and she is a CPAP dependent. Bowel and bladder habits are normal. Allergies, no known drug or food allergies. Drug history, she is using CPAP at night time. Her functional capacity METs more than 4. Family history, non-contributory. General physical examination, she is conscious, coherent, cooperative, well-oriented to the time, place, and person. Build is obese. Weight is 115 kgs. Height is 155 centimeters. BMI is 47.9 kg per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, and generalized edema. Her vitals are stable with pulse rate 96 per minute, blood pressure 130 by 80 millimeters of mercury, respiratory rate is 16 per minute, SpO2 98% on room air, fever, temperature, febrile. Airway examination, mouth opening is adequate, temporomandibular joint normal, Malampati grade 3, dentition, no loose teeth or artificial dentures, thyromental distance less than 3 finger breadth, neck circumference is 41 centimeters. Spine examination, landmarks are not well defined. Coming to systemic examination, respiratory system, bilaterally normal vesicular blood sounds heard, no added sounds. Cardiovascular system, there is no raised JVP. First and second heart sounds heard, no murmurs. Central nervous system, there are no focal neurological deficits. Abdominal examination, inspection, abdomen is obese and distended, umbilicus centrally placed and deeply recessed. Skin striae are present, no scars or dilated veins, no visible peristalsis or pulsation. Palpation or superficial palpation, abdomen is soft, mild right hypochondrial tenderness present, no guarding or rigidity. On deep palpation, it is difficult due to thick abdominal wall. Liver and gallbladder not palpable, no palpable masses, and spleen not palpable. Percussion, predominantly tympanic note. Liver dullness, difficult to delineate, no shifting dullness. Auscultation, bowel and bladder habits. Auscultation, bowel sounds present and normal, no abdominal ROE. To summarize this case, it is a 42-year-old female patient with BMI 47.9 kg per meter square who belongs to obesity class 3, was admitted in hospital with chief complaints of pain in right upper part of abdomen since 4 days associated with vomitings, was diagnosed with cholelithiasis, posted for surgery, laparoscopic cholecystectomy.
Can you classify obesity?
Yes, ma'am. According to WHO, depending on BMI, we can classify the obesity, ma'am. If it is less than BMI is if it is less than 18.5 kg per meter square, it is underweight. If it is 18.5 to 24.9, it is normal weight. If it is 25 to 29.9, it is overweight. More than 30, we call it as obese, ma'am. If it is 30 to 34.9, it is class 1 obesity. 35 to 39.9 class 2 obesity, and 40 to 49.9 it is class 3 obesity. If it is more than 40, we call it as morbid obesity, ma'am. If it is more than 50, we call it as super obese. If it is more than 60, it is super obese. If it is more than 70, it is called as ultra obese.
Okay, so your patient comes under class 3.
Class 3, ma'am.
Or it reaching almost into the next.
Yes, ma'am.
Okay. So this case is a real case or you have made it?
It is a real case, ma'am. My senior actually took this case. I took from her.
Acha. Because I had a doubt.
Madam, excuse me, madam. Excuse me, madam. Manjula, madam. Can I just take over, madam? Can I just take over?
No issues, no issues.
Okay. Amala, can you just answer what are the types of obesity and classify them?
Yes, ma'am. There are two types of obesity, ma'am. Android obesity and gynecoid obesity. Android obesity, we will call it as a central obesity also. And here the adipose tissue is concentrated around upper part of the abdomen. And in this fat is metabolically active and there will be high oxygen consumption. So there will be increased risk of cardiovascular diseases. And for gynecoid obesity, it is also known as peripheral obesity. Here the adipose tissue is mostly concentrated around the buttocks, hips and thighs. Here this fat is metabolically inert, so there will be less oxygen consumption and reduce the risk of cardiovascular diseases. It is more common in female, ma'am.
What is the most commonly used quantifier of obesity?
BMI, ma'am.
Okay.
According to Quetelet Index, BMI formula is weight in kgs divided by height in meters square, ma'am.
Okay. So what are the limitations in using BMI as an index?
We generally quantify obesity according to BMI, but it has its own limitations, ma'am, because it does not distinguish between the lean body mass and fat, and it does not tell anything about fat distribution, whether it is gynecoid or android, and it does not tell anything about ethnic variations also, because Asian populations have more metabolic risks with less BMI value also. So here we can take a waist hip ratio also as a complementary measure to BMI.
So how do you measure and what is the significance of waist hip ratio? Tell me more about it.
Waist hip ratio is nothing but waist circumference divided by hip circumference, ma'am. Waist circumference will measure at midpoint between the lower costal margin and iliac crest at the end of normal expiration, and hip circumference will measure at the widest part of the buttocks. Waist to hip ratio, if it is more than 0.8 in female, if it is more than 1 in male, they are high risk for candidates for ischemic heart disease, stroke, diabetes mellitus, and this waist hip ratio tells about the fat distribution. In BMI, we cannot tell anything about fat distribution.
What are the values of waist circumference which determine the risk? What are the values in male and female?
Male waist circumference, if it is more than 102, if in female, if it is more than 88 centimeters, then they are high risk candidates for developing ischemic heart disease, diabetes mellitus, hypertension, madam, and stroke also. Waist circumference tells about the abdominal fat, correlates with the abdominal fat.
Okay. How do you accurately measure the obesity? Maybe not very commonly used, but tell me the other modes of measurement of body fat content.
To measure body fat content, it is not that it is, ma'am. We have to use sophisticated methods like CT scan, MRI scan, and electrical impedance studies. We can use clinical approaches also, like anthropometric measures, like skin fold thickness, that will measure at the biceps, triceps, intrascapular region, and suprailiac area. And we can use BMI, waist hip circumference, and waist circumference, and densitometry, underwater weighing also.
What are the causes of obesity?
the basic cause, one of the important causes, there will be mismatch between the calorie intake and energy expenditure. If there is more calorie intake and less expenditure of energy, that can be one of the cause, ma'am. It will be influenced by other genetic, environmental, behavioral, cultural, and socio-economic factors. And obesity is associated with genetic syndromes, especially like leptin deficiency, Prader-Willi syndrome, Lawrence-Moon-Beadle syndrome. Other causes are taking OC pills, certain drugs like OC pills, psychiatric medications, antidepressants, and associated with other endocrinal abnormalities like hypothyroidism, Cushing syndrome.
Okay. Briefly about can you tell me briefly about the pathophysiology of obesity?
Obesity ultimately leads to insulin resistance and inflammation, atherosclerosis, and hypertension, and increase in fat deposition. This is all mainly because of increased calorie intake and decreased fat physical activity. Now, it leads to positive energy balance. This increased energy will be stored in triglycerides, and these triglycerides will be stored in adipocytes. So adipocytes will become hypertrophied and hyperplasia, and adipocyte itself acts as an endocrine organ. It causes increase in the leptin, causing leptin resistance, decrease in adiponectin, and increase in inflammatory markers like tumor necrosis factor alpha, interleukin 6. They all leads to hyperinsulinemia, hyperglycemia, and they causes low-grade inflammation, which causes endothelial dysfunction, atherosclerosis, hypertension, coronary artery disease, and there will be increase in the fat deposition, which causes mechanical effects.
So, what are the comorbidities associated with obesity? Describe in briefly in each and every section. Okay, and as you are planning to go for a lap cholecystectomy, what are the effects of laparoscope pneumoperitoneum on these systems along with obesity? Let me know.
According to system wise, we'll go through, ma'am. Obesity in respiratory system, obese people most commonly have obstructive sleep apnea, obesity hypoventilation syndrome, restrictive lung disease. In case in lab, coming to respiratory system, there will be changes because of two reasons, ma'am. One is we are creating pneumoperitoneum that causes increase in intra-abdominal pressure, which causes shift of the diaphragm, scapular shift of the diaphragm, which decreases FRC. So it leads to atelectasis, ma'am, and there will be increase in peak airway pressure, peak plateau pressure, airway resistance increases, ma'am, compliance reduces, so it leads to VQ mismatch and hypoxia, ma'am. That is one of the reason, that is rise in intra-abdominal pressure. And another reason is raised PaCO2 values. In case if the patient has cardiopulmonary diseases, there will be increase in PaCO2 and there will be increase in EtCO2 also, because there will be no increase in physiological dead space. So the patient can excrete, exhale all the excess of PaCO2. So EtCO2 also raises. So the gradient is constant in them. So we can safely rely on the EtCO2 levels. But if the patient has cardiopulmonary diseases, the EtCO2 cannot, won't raise even if PaCO2 rises because of physiological shunt. So PaCO2 will increase, but EtCO2 won't increase. So in those cases, with cardiopulmonary patients, cardiopulmonary disease patients, we should not rely on EtCO2 in respiratory system. And in coming to cardiovascular system, obese people are most commonly associated with systemic hypertension, coronary artery disease, congestive heart failure, cerebrovascular disease, peripheral vascular disease, pulmonary hypertension, hypercoagulable syndromes, hypercholesterolemia, hypertriglyceridemia, sudden death also can happen. And in lab in laparoscopic cholecystectomy, we are again the cardiovascular changes are because of two reasons, ma'am. One is increase in the intra-abdominal pressure and increase in PSEO2. There will, if there is a biphasic response, ma'am, if there is intra-abdominal pressure less than 15, there will be squeezing of blood from the splanchnic vascular bed. So there will be increase in venous return, there will be increase in the cardiac output. So there will be increase in the mean arterial pressure. But if the intra-abdominal pressure crosses more than 15, there will be compression of IVC. So there will be reduction in the cardiac output, venous return, and reduction in the cardiac output. So mean arterial blood pressure reduces. This is one of the reason. And another reason is raised PaCO2, hypercarbia. It stimulates the sympathetic nervous system. So it causes increased myocardial contractility. So systemic vascular resistance increases. So ultimately mean arterial blood pressure increases. Endocrine system. Metabolic obese people are associated with metabolic syndrome, diabetes mellitus, Cushing syndrome, hypothyroidism. And coming to gastrointestinal system, they are associated with NASH, non-alcoholic steatohepatitis, hiatal hernia, gallstones, fatty liver infiltration, gastroesophageal reflux disease, delayed gastric emptying.
What is metabolic syndrome? What is metabolic syndrome?
Metabolic syndrome, we call it as syndrome X. The features the components are abdominal obesity, that is waist hip circumference ratio 0.8, more than 0.8 in female, more than 1 in male. High blood pressure, it is more than 130 by 85 millimeters of mercury. Increased in FVS, that is more than 100 mg per deciliter. Decreased HDL in males if it is less than 40 mg per deciliter. In female if it is less than 45 mg per deciliter. Increased triglyceride levels, that is if it is more than 150 milligrams per deciliter. Then if presence of any 3 or more components among them, we call it as metabolic syndrome.
How are the other systems affected?
Coming to musculoskeletal system, because of excessive waste, osteoarthritis, joint pain, back pain will be there. And in them, pancreatic, breast, prostate cancers are very common. And cervical, uterine, endometrial, colorectal cancers are also common. Other characteristic features are they might be associated with a depression, overall shorter life expectancy.
So why is this case, obesity, complicated lap cholecystectomy, a challenging case for an anesthesiologist?
The challenges starts with shifting itself, ma'am. But the most important challenges while managing the case are obesity. Obese people are associated with so many comorbidities, and they might have difficult airway. On the top of it, we are creating pneumoperitoneum in lap cholecystectomy, and there will be drastic positional changes. So in surgical wise, prognosis wise, lap is advantageous for the patient, but anesthesia wise, it is a bit challenging.
Okay.
What is anesthetic management for this case?
Sir, in PAC, preoperative assessment, apart from the routine preoperative checkup, will mostly focus on the airway examination, sir. They might have difficult airway, and in preoperative advice, we'll put strict NBM guidelines. We avoid sedatives, and we'll plan deep venous DVT prophylaxis, and we'll counsel the patient properly according to ERA's protocol. And while we have to during the while shifting the case, we'll arrange a trained adequate manpower. In OT, we'll be prepared with larger masks, larger airways, adequate OT table with larger BP cuffs, and a difficult airway cart should be ready. And laryngoscopes, different sizes of the laryngoscope blades with the short handles, and after putting the patient on the table, we have to strap him to prevent sleep.
So you don't want to
prevent
have
sleep
any.
Amala, what is the most important concern for an anesthesiologist, respiratory-wise, in an obese patient?
According to respiratory wise, the most important concern is obstructive sleep apnea, ma'am. Because obstructive sleep apnea are associated with difficult airway, there will be difficulty during mask ventilation and intubation. There will be reduced ventilatory drive in obese people, and if we give opioids and benzodiazepines, they further suppress the respiratory drive, and rapid desaturation will be there because of low FRC and low oxygen reserve. And after extubation, they might airway upper airway collapse might be there, and it causes post-operative obstruction. And while managing the haze during intubation, there will be a high cardiac stress because of pulmonary hypertension and arrhythmias.
What is OSA? How will you elicit the history of OSA?
OSA is obstructive sleep apnea. The definition is episodic complete cessation of breathing more than 10 seconds, occurring more than 5 times per hour, with desaturation more than or equal to 4%, despite the maintenance of normal neuromuscular ventilatory effort. Apnea occurs because of collapse of pharyngeal tissues.
What is obstructive sleep apnea? What is obstructive sleep hypopnea? How do they differ? Do they differ from each other?
Yes, ma'am. In obstructive sleep apnea, complete cessation of breathing will be there. It lasts for more than 10 seconds or 10 seconds. But in obstructive sleep hypopnea, there will be partial reduction of airway that is greater than or equal to 30%. And it also lasts longer for 10 seconds. In obstructive sleep apnea, we tell it as obstructive sleep apnea if it is present 5 or more than 5 times per hour, and we'll consider obstructive hypoapnea if the hypopneic episodes are 15 or more than 15 per hour in sleep. In both cases, there will be reduction of saturation by 4% than the baseline.
Okay. How do you elicit the history of from patient in obstructive sleep apnea? What history do they give?
We'll ask the symptoms like disturbed night sleep, daytime somnolence, impaired concentration during daytime, memory problems, and motor vehicle accidents, and early morning headaches because of hypercarbia during nighttime. We'll ask these symptoms now. And we can ask another questionnaire also, a stop bang questionnaire.
What is that? What is the stop bang questionnaire?
Stop bang questionnaire, we have as per snoring, ma'am. We'll ask the patient, do you snore that is loud enough to be heard through the closed doors? And T for tiredness, are you feeling tired during daytime? Has anyone observed you stop breathing during the night sleep during nighttime? And P for pressures, like do you have blood pressure, high blood pressure, and are you being treated by any other BP medications? And B for BMI more than 35 kg per meter square, ma'am. A for age, age is more than, if age is more than 50 years. N neck circumference, ma'am, more than 40 centimeter. G gender, ma'am, if male gender. In case if he says S to any of 3 or more questions, there will be high risk for obstructive sleep apnea. If less than 3, if it says S to less than 3 questions, it will be low risk for obstructive sleep apnea.
What are the physiological changes you see in OSA?
Physiological changes in OSA, there will be hypercarbia and hypoxemia, ma'am, so that they will have this polycythemia, systemic hypertension, and pulmonary hypertension, right ventricular failure, or pulmonary they might have.
How do you diagnose and treat OSA?
The definitive diagnosis is polysomnography, ma'am. Polysomnography in sleep laboratory, ma'am. Treatment.
No. What is the apnea hypopnea index? What is it?
Apnea hypopnea index is number of apneic episodes plus hypopneic episodes per divided by number of hours of sleep. It assesses the severity of obstructive sleep apnea, ma'am. It can be assessed by polysomnography. Interpretation is if apnea hypopnea index, if it is 5 to 15 episodes per hour, it is mild, and the treatment will be weight loss, lateral sleeping position, and we have to suggest we have to encourage him for alcohol avoidance. And if the apneic hypopneic index is 15 to 30 episodes per hour, the treatment is CPAP or BiPAP. It comes under moderate category. And if it is more than 30 episodes per hour, it comes under severe category. Then we can go for surgical approaches like uvulo-palatopharyngoplasty.
What is the treatment modality of OSA?
Application, we can application of positive airway pressure, ma'am, through CPAP or BiPAP. If the patient is not tolerating positive air pressure, then we can go for oral appliances which will push the tongue anteriorly and also mandible forward. If it is severe sleep apnea, that means if it is apneic hypopneic index is more than 30, we have to go for surgical treatment like uvulo-palatopharyngoplasty, tracheostomy, maxillofacial surgeries. In any severity, we have to suggest him for weight loss, which improves OSA symptoms significantly.
What is Pickwickian syndrome and its relevance to the anesthesiologist?
First, obstructive sleep apnea. If it long-term obstructive sleep apnea will leads to obesity hypoventilation syndrome. The difference is in obstructive sleep apnea, nocturnal hypocarbia will be there. There will be no central desensitization in obstructive sleep apnea. After long-term obstructive sleep apnea, the respiratory center will become desensitized to increased CO2. Then the patient will have hypercarbia during wakefulness also, during the daytime also. They have daytime hypercarbia more than 45 mm mercury plus hypoxemia. This is called as obesity hypoventilation syndrome. Here the management is overnight NIV. If we don't treat obesity hypoventilation syndrome on a long term, it progresses to Pickwickian syndrome. Pickwickian syndrome is nothing but they have all the obesity, obstructive sleep apnea features, and they have this structural impairment like pulmonary hypertension and right ventricular hypertrophy. So even light sedation also they can lead to cardiac arrest in Pickwickian syndrome. So we have to be thoroughly assess whether they have obstructive sleep apnea, obstructive obesity hypoventilation syndrome in the PSC.
Okay, what will you do like in an obese patient without a documented history of sleep apnea? You go for a stop bank questionnaire.
And there is another
and what
questionnaire
question?
also.
What is it?
Berlin questionnaire, it has 10 questions with 3 categories like snoring, daytime sleepiness, or other comorbid hypertension and all. This is also we can use, but it is cumbersome compared to stop bank questionnaire. Mostly we'll use stop bank questionnaire.
What are the respiratory system changes in an obese patient?
The respiratory system changes are mainly because of deposition of redundant tissue around the upper airway, around the neck, around the thorax, and so there will be changes in the lung volume, lung compliance, gaseous exchange, and work of breathing. in obese people, they have obstructive pattern also, and restrictive pattern is more predominant than the obstructive pattern. They have restrictive type of lung diseases, and because of added weight around the thoracic cage, they have a reduction in the functional residual capacity, expiratory reserve volume, and total lung capacity will be reduced, and there will be reduction in inspiratory capacity and vital capacity also. The FRC reduces so much that closing capacity will become more than FRC. It leads to small airway closure, ma'am. So there will be shunting of the blood, V by Q mismatch, and hypoxia will be there. So in obese people, FRC will reduces by 50%, whereas in normal people, FRC reduces by 20% only after giving anesthesia. They have chances of a very rapid desaturation in apneic during apnea and become apneic. During apneic episode, they will become rapidly desaturated. So proper pre-oxygenation is very important before intubation now. And they have a high basal metabolic rate, so there will be increase in the CO2 production and oxygen consumption. So they have a high metabolic rate, so there will be increase in the minute ventilation, increase in respiratory rate also. There will be rapid shallow breathing pattern, and there will be reduction in lung compliance, ma'am, because of deposition of adipose tissue fat around the chest wall. So the lung compliance is also reduced.
So there are lots of changes in the respiratory system, and OSA is present in obese patients. What are the implications for us?
As they have so many respiratory system changes in PSC, additionally we can order for a pulmonary function test, and ABG should be done preoperatively to check the baseline PSCO2 levels, and pre-oxygenation should be done for 5 minutes pre-oxygenation before intubation, and we have to go for higher inhalation pressures because of lung compliance is very less in them, and application of PEEP to improve the oxygenation, and we have to avoid sedative pre-medication in the ward, and in OT also after applying all the monitors under supervision, we have to give sedative medications, that too with less doses.
What are the changes which occur in CVS in obese patients? In detail.
The most common serious manifestations related to obesity are systemic hypertension, coronary artery disease, and heart failure, ma'am. They all are because of hyperinsulinemia, because hyperinsulinemia leads to increased levels of circulating norepinephrine, which causes increase in the blood pressure, and there will be they activate adipocytes, which releases angiotensinogen, which further leads to RAS activation, sodium retention, hypervolemia, increase in the cardiac output, and there will be increase in circulatory inflammatory markers, and they causes fibrosis and arterial stiffness, which further increases systemic blood pressure. So that is for why they have systemic hypertension, and they have coronary. They are commonly associated with coronary artery disease, ma'am, because obesity is commonly associated with dyslipidemia, chronic inflammatory state, and it is a chronic inflammatory state. They have hypertension and diabetes mellitus, and they all increases coronary artery disease, ma'am. And heart failure.
Yeah, why is there heart failure in obesity?
Here they have biventricular dysfunction, ma'am, because they have arterial wall stiffness, circulatory overload, left ventricular hypertrophy, and left ventricular dysfunction will be there. Because they have pulmonary arterial hypertension, they have right ventricular failure also, so they have biventricular dysfunction.
What are the gastrointestinal tract changes and their implications in anesthesia for us?
There will be increased intra-abdominal pressure, which leads to increased gastroesophageal reflex. So they have associated with high risk of aspiration, ma'am. Even after 8 hours of fasting, 90% of morbidly patient, they have 25 ml of intragastric volume, that pH with pH less than 2.5. Hence, we have to give metoclopramide and ranitidine preoperatively. There will be increased risk of aspiration, and associated diabetes mellitus also increases risk of aspiration as they have gastroparesis associated with diabetes, and we have to go for rapid sequence intubation after giving adequate pre-oxygenation.
What are the other important changes in obesity?
Thromboembolic disorders, the obesity is a hypercoagulable state, so DVT is common. So we have to go for pharmacological or mechanical therapies like pneumatic compression stockings. Musculoskeletal disorder, because of overweight, joint degenerative joint diseases will be there, like osteoarthritis. So while shifting the patient, while positioning the patient, we have to be careful. And nervous system, coming to nervous system, autonomic nervous system dysfunction will be there, peripheral neuropathy will be there. So adequate padding should be done to prevent pressure necrosis.
What are the general problems we encounter while dealing with obese patients?
General problems are while doing PAC, adequate size of the chair should be available, and while shifting the patients, adequate size of stretcher, adequate manpower should be there, and in OT, adequate BP cuff should be there with adequate sizes of mask and oral airways. OT table is generally not sufficient for them, so we have to combine 2 OT tables. Generally, our OT table capacity is 200 kgs, so we have to combine 2 OT tables, and there will be difficulty in eliciting physical signs like dehydration. Skin changes we cannot appreciate that much, so signs of dehydration are not very obvious.
How do you stratify their risk pertaining to surgery? Stratify the risk.
There is obesity, surgery, mortality risk score is there now. Here 5 components will be there. First one, arterial hypertension. It scores 1 point. If it is age, if it is more than 45, 1 point. Male gender, 1 point. BMI more than 50 kg per meter square, it gives 1 point, and risk factors for pulmonary thromboembolism, it gives 1 point. If the score is 0 to 1, they comes under low risk with post-operative mortality 0.3. If the score is 2 to 3, they come under moderate risk with the post-operative mortality 1.7. If the score is 4 to 5, they come under high risk category with post-operative mortality 3.2.
What is your specific goal in PAC in obese patients, apart from general goals and optimization?
Specific goal in PAC is our aim, our focus should be mainly there on airway examination, ma'am. Predictors of difficult intubation are if the Mallampati score is 3 or more, if the neck circumference is more than 40 at thyroid cartilage, if thyromental distance is less than 6 centimeters, if they have short, thick neck, decreased incisor gap, sternal pad of fat, limited mobility of temporomandibular joint or occipital joint, if they have a very high BMI with a large breast, they all suggest difficult intubation.
What are the specific investigations you order for when the patient is planning to undergo lap cholecystectomy?
We have to go for CBC, complete blood count, ma'am. Hemoglobin, as they have, obese people have a polycythemia, and WBC count we have to ask because they have cholecystitis, and platelets for baseline values, and we have to order for HbA1c because mostly obese people are associated with diabetes, and liver function test because in cholelithiasis there will be raised bilirubin and liver enzymes levels increases in cholecystitis, and obese people are associated with non-alcoholic steatohepatitis, ma'am. So we have to order for liver function test and PTINR, lipid profile, thyroid function test because they are associated with hypothyroidism. To assess the cardiac status, we have to order for ECG, 2D echo, chest X-ray, ABG, and PFT. PFT, if there is a poor exercise tolerance, then we can order for PFT.
How do you optimize them? What are the specific measures you take?
In preoperative optimization, we have to reassure the patient and adequate. We have to optimize all the comorbid conditions, and we have to order for incentive spirometry and breathing exercises, and we have to plan for thromboprophylaxis preoperative only. And if he is on diabetic medications except insulin and oral hypoglycemics, we have to continue all other medications. Antibiotic prophylaxis is important because there will be increased risk of post-operative wound infections, and he has to follow strict NBM guidelines to reduce the aspiration risks, and we have to avoid sedative drugs in the ward.
What is the care you take before shifting the obese patient to the OT?
Again, we have to combine two standard OT tables to accommodate the patient if needed. And the current OT table standard is 200 kgs. And while transferring air transfer mattress device, we can use hover mat if available. And after shifting the patient into OT, on the OT table, we have to strap the patient to prevent a slip off from the OT table. And adequately trained manpower should be there for shifting and positioning of the patient. And after positioning, we have to strap, and adequate padding should be done.
How will you prepare the operating theater for this obese patient?
In OT table, adequate OT table should be there, adequate BP cuff should be there, and we have to be prepared for difficult IV cannulation and the central line. If the adequate BP cuff is not there, we have to go for invasive blood pressure also to secure the arterial line, and larger masks for ventilation should be there with bigger size oral airways with different blade size with short handles. After positioning the patient, adequate paddings for pressure points, so we have to arrange for paddings, and we have to be ready for difficult intubation, ready for awake intubation also. If the with patient consent, if the patient is cooperative, we have to plan for awake intubation. We have to be ready for difficult airway. Video laryngoscope should be available, fiber optic bronchoscopy with and laryngeal mask airway should be available. Tracheostomy kit should be kept ready with resuscitation drugs.
Okay, why did you talk about invasive arterial blood pressure? What other roles has it got?
If the
tell me. When will
there is if there is a non-availability of adequate blood pressure cuff, if NIBP will give false values, then we can use invasive blood pressure monitoring. And in case if he is associated with cardiopulmonary diseases, we can go for invasive blood pressure.
Well, repeated ABGs?
Repeated ABG, we have to take for repeated ABGs.
It guides us in ventilation. Okay.
Yes.
So, any special positioning for this patient?
Rather than going for sniffing position, we'll prefer ramped up position, ma'am. In obese people, ramped position with stacking of towels and blankets under the neck, shoulder, and upper back. Here we have to make sure that external auditory canal is in line with the sternal notch. They should be at the same level. It increases the laryngoscopy view. It improves the laryngoscopy view. And we can use reverse Trendelenburg also, head up also, 25 to 30 degrees head up position.
Talk about the role of awake intubation in these patients.
It is safe if we do awake intubation because it reduces the airway risk, ma'am. But if the patient is cooperative and if he gives consent only, then we can go for awake intubation.
How will you manage the airway here? Talk in detail. Why is it a concern for us?
Our concern is rapid desaturation, ma'am, because of reduced lung compliance, reduction in the FRC, and reduction in FRC. To prevent a rapid desaturation, we have to position the patient 25 to 30 degrees head up position or ramped up position. And we have to pre-oxygenate the patient with 2 hands. Assistance is needed here. for 5 minutes we have to pre-oxygenate with 100% oxygen, with providing continuous positive airway pressure at 10 centimeters of water. It increases the apneic time without desaturation by 50%.
What are the other issues you address?
After adequate pre-oxygenation, then we have to induce the patient, ma'am. Then we have to go for larger doses of induction, as there is increased volume of distribution, and we have to go for rapid sequence intubation with the scoline or rocuronium, ma'am. We have to use scoline with at higher doses, because there will be increase in pseudocholesterol activity. And as we are going through, as the surgery is the laparoscopic cholecystectomy, before intubation, before induction, we have to put the Rales tube, and we have to aspirate all the gastric contents. It prevents aspiration, and while inserting the trocars and Berry's needles, if we push the Rales tube, there will be less chance for the stomach damage.
Okay. What is Thrive?
Thrive is a transnasal humidified rapid insufflation ventilatory exchange, ma'am. It is a type of apneic oxygenation. In this, while securing the airway, we'll provide continuous oxygen supply at a high flow at 30 to 70 liters. We'll use via nasal cannula. Warmed humidified oxygen will use, ma'am. It provides continuous oxygenation and some CO2 washout while we are securing the airway. So it extends safe apnea time during the airway management.
How do you go about intubation?
By PAC, we will know whether there is difficult intubation. Unless we should anticipate difficult intubation in obese patients. So we'll use video laryngoscope, and if we anticipate a difficult intubation, it's better to go for awake fiber optic bronchoscope, and rescue devices in the form of second generation LMA should be available, and trained staff should be there for securing a surgical airway. We have to inform the surgery people for front of neck access for fauna, and tracheostomy consent should be taken preoperatively.
Okay. So, what are the various drugs used in, and how are they used? How are they dosed? Depending on what are they dosed? What is the total body weight? What are the different? How are they dosed? Different drugs.
Lipophilic drugs, because they have high volume of distribution, we have to give them according to total body weight, like propofol maintenance doses, benzodiazepines, atracurium, cisatracurium, fentanyl, sufentanil. We have to give according to total body weight, ma'am. And succinylcholine also we have to give according to total body weight. And hydrophilic drugs, as they have, we have to give according to ideal body weight, ma'am. Vecuronium, rocuronium, Sugamadex, remifentanil, propofol loading doses also according to ideal body weight we have to give.
So
ideal body weight.
Yes. So 1 minute, Amala. So out of all the available drugs, which one you feel better for intubation and maintenance? That the available drugs. Don't mention about all the bookish drugs.
Our main aim should be we have to give all short-acting drugs, sir.
Yeah.
So with the succinylcholine, we can intubate, sir. For maintenance, desflurane is a preferable agent, sir. We have to avoid nitrous oxide. We can maintain the patient with desflurane, and for pain management.
Did you ever try rocuronium?
In my institute, rocuronium is not available, sir, so we didn't try.
Rocuronium is supposed to be the best drug for the intubation and for maintenance also. So it has a better cardiovascular stability when compared to vecuronium, and there is some intraoperative things which is better with rocuronium when compared to vecuronium, especially with this patient. So can you tell what it is?
Intraoperatively, because we are handling the laparoscope equipment. So once that touches any ligament or sort of thing, that have a potential to cause bradycardia and arrest also. So when compared to acronym, the tracronium has a better cardiovascular stability. So always you pitch up for giving rocuronium for intubation and for maintenance also when compared to acronym and scoline combination. Okay.
Okay, sir.
Yes. Now you can go ahead, please.
What are the monitoring devices you use? How will you maintain the anesthesia?
Pulse oximetry, ECG, ETCO2, temperature probe, NIBP, or sometimes invasive blood pressure, urine output monitoring, glucose monitoring should be there, and neuromuscular monitoring, train of 4.
Good.
And if available, bispectral index.
Yes. Yeah.
How do you maintain the patient?
Our main aim should be there should be rapid recovery. So we'll use short-acting agents only. We have to avoid nitrous oxide here because obese people are associated with pulmonary hypertension, and in lap surgeries generally we do avoid nitrous oxide, and we'll use a rapid short-acting agent. Desflurane is preferred than sevoflurane as there is rapid recovery in desflurane, but we have to consider that carbon footprinting, that is greenhouse effect also for desflurane. So we can go for sevoflurane also. Remifentanil or sufentanil is preferred. Short-acting agents like cisatracurium and atracurium we can prefer because they can go through organ-independent elimination and they're short-acting also. And dexmedetomidine is preferred anesthetic adjuvant due to its minimal respiratory depressant effects.
How about the fluid management?
Fluid management, we should not underload the patient, we should not overload the patient, we should go through goal-directed fluid therapy. Larger fluids they cannot tolerate well because they can develop pulmonary edema. If there is less blood pressure, less mean arterial blood pressure, gas embolism chances will be high. So we have to give fluids cautiously according to goal-directed fluid therapy.
So what is the preferable method of anesthesia in this case? Is it general or regional?
In this case, obesity and with obesity for laparoscopic cholecystectomy, we have to go for general anesthesia for with epidural anesthesia for postoperative analgesia. But in obese people, generally we can go for regional anesthesia safely. As there will be postoperative analgesia, there will be no need for giving opioids, so there will be less respiratory depression if we go with regional anesthesia in obese people, and we have to give less local anesthesia in case if we use regional anesthesia in obese people, ma'am.
Amala, 1 minute. Actually, madam asking regarding the anesthetic management of this case, not the general cases.
In this case, we have to go for general anesthesia, ma'am, with epidural anesthesia for post-operative analgesia.
Good, yeah.
Okay. What about regional anesthesia in obese patients in general? What are you were talking about something?
In obese people, regional anesthesia is preferred than general anesthesia, generally, not in lab cases, because regional anesthesia they provide post-operative analgesia, so we can avoid post-operative opioid use for pain management. So it reduces the risk of respiratory depression, and the anesthetic dose requirement also it is less, that is 20% less than in general people. But giving regional anesthesia is a bit difficult in obese people because there will be we cannot appreciate the landmarks that well. So if we use ultrasonography, there will be high chance for success rate of regional anesthesia.
In this case, what are the ventilatory parameters you will go for?
Ventilatory parameters, we have to go for low tidal volumes, ma'am, 6 to 8 ml per kg per minute. Pressure control ventilation is preferred than volume control mode, and we have to maintain the PEEP pressures at 10 to 15 centimeters of water, and we have to maintain the peak airway pressure and peak plateau pressures at less than 30 centimeters. And if there is hypoxia, we have to use recruitment maneuvers, ma'am. Even though if we increase the tidal volume, there will be no increase in the saturation in obese people that much. So we have to use recruitment maneuvers like sustained inflation technique and a stepwise increase in PEEP. Sustained inflation technique is inflating the lungs at 55 centimeters of water for 10 seconds. And
no, it is 50 centimeters water for 10 seconds. It is not 5 centimeters.
55, okay.
Yeah, 55 centimeters.
Yes, ma'am. 50 centimeters of water at 10 seconds, ma'am. And after that, we have to set a PEEP. And we have to do it intermittently because they all leads to hemodynamical disturbances. We have other approaches, stepwise increase in the PEEP, ma'am. Gradually, we have to increase the PEEP to prevent atelectasis, ma'am. That increases saturation levels.
Okay. What is the other measures you take during pre-oxygenation? Do you apply CPAP or what do you do during pre-oxygenation?
Yes, ma'am. For continuous 5 minutes, we have to pre-oxygenate with 100% oxygen, ma'am. While with the CPAP, with using CPAP at 10 centimeters of water pressure.
Okay.
So what is this other terminology called? Like pre-oxygenation for 5 to 10 minutes. Is there any terminology given for this? It is called denitrogenation. Okay.
Denitrogenation.
Okay. Yes. Yeah. Go ahead. Yeah, please.
What are the extubation criteria?
If the patient is awake with spontaneous efforts and tidal volume respiratory rate are if they are at pre-op levels, and if they are able to sustain head lift for 5 seconds with constant hand grip, if they are obeying verbal commands, then we can extubate the patient.
Okay. So how do you extubate and what is your post-operative management?
If adequate neuromuscular reversal with a train of 4 ratio 0.9 is there, we can plan for extubation, and we have to extubate the patient in semi-recumbent position. If we anticipate if there was a difficult airway, we have to extubate with an airway exchange catheter, ma'am. Before extubation, we have to provide PEEP or CPAP so that it reduces airway collapse after extubation. And it prevents atelectasis also immediately after extubation. So before extubation, we have to provide PEEP, and we have to extubate our airway exchange catheter. And after extubation, we should not shift the patient to recovery room immediately. We have to observe the patient immediately after extubation. We have to provide CPAP, and we have to.
Please go ahead.
To maintain the airway patency, nasopharyngeal airway placement is necessary in those obese people. Oxygen supplementation is required till patient is shifted to recovery room. And during shifting also, we have to maintain the verbal contact with the patient to assess the wakefulness.
So what is the post-operative care you're going to give to this patient? What are the problems you might be facing and what is the care you're going to give?
Main post-operative problems are post-operative hypoxia because of collapse of pharyngeal tissues, post-operative nausea, vomiting, pain, DVT, hypoventilation, which can lead to pneumonia also. So post-operatively, we have to put the head and elevation. We have to do close monitoring and ABGs when send ABG samples when required. And post-operatively, as this patient is already on CPAP pre-operatively, we have to continue the CPAP post-operatively. We have to provide good analgesia, early ambulation, breathing exercise should be done, chest physiotherapy and spirometry. DVT prophylaxis also should be given.
How do you manage pain after lap cholecystectomy?
In laparoscopic cholecystectomy, the pain is because of first one because of incisional pain, ma'am, at the incisional site. Another one is visceral because of pain at the visceral structures, and another one is referred pain from the subdiaphragmatic region as shoulder pain, ma'am. The shoulder pain, that is a referred pain, we can that is because of irritation of the diaphragm by CO2 gas. So before closure, we have to evacuate all the gas completely. So it reduces the shoulder pain. And visceral structure pain, it is mainly because of inflammatory markers and residual blood, ma'am, because blood can irritate, blood irritates the peritoneum. So we have to give saline wash before closure, and we have to evacuate all the blood. We have to suction the blood, and at incisional site, to reduce the pain, we can go for local infiltration with local anesthetics, and intraperitoneal instillation also we can do. That is better than intra-incisional local infiltration for pain management. And it is lap cholecystectomy, ma'am. So we can go for bilateral, subcostal, transverse abdominal spleen block, tab block, and we can go for erector spinae block and quadratus lumborum block also. We have to provide multimodal analgesia, opioid-free multimodal analgesia with IV paracetamol, NSAIDs like diclofenac, ketorolac, alpha-2 agonist. Patient control analgesia is preferred.
Yeah, ma. So go ahead. Yeah.
Yeah. So, what is the role of IRAS in this case? How do you go about that? What is IRAS, first of all?
IRAS is enhanced recovery after surgery, ma'am. The main aim is, the main benefit is it reduces the morbidity after the surgery, and it reduces the length of hospital stay also. As a part of IRAS protocol, preoperatively, we have to counsel the patient, and we have to optimize the patient. So we have to limit the fasting hours. We have to give carbohydrate beverages until 2 hours prior to the surgery, and we have to plan for DVT prophylaxis perioperatively and post-operative nausea vomiting prophylaxis. Intraoperatively, we have to give optimal fluid management and adequate analgesia with small incisions, and we have to avoid drains also. Intraoperatively, we have to maintain normothermia, normoglycemia, euvolemia. Post-operatively, we have to give adequate analgesia and we have to give treatment and prevent post-operative nausea vomiting, and if it is there, we have to treat post-operative nausea vomiting, and early removal of catheters, early mobilization, and early oral nutrition also we have to do, ma'am. This is all to improve, decrease the length of stay in the hospital.
So, what are the treatment modalities of obesity per se? What are the treatment modalities for obesity?
First one is behavioral interventions, ma'am. We have to encourage him for less caloric intake and for doing exercises. Medical management is using certain drugs like orlistat, then naltrexone, bupropion, liraglutide, semaglutide, and phentermine, topiramate. These are the medical pharmacology, ma'am. We can go through. And surgeries for obesity are there are 3 types of surgeries, ma'am. One is the restrictive surgeries, that is adjustable gastric banding and sleeve gastrectomy. Malabsorptive procedures are biliopancreatic diversion. Combined procedures like restrictive and malabsorptive, Roux-en-Y gastric bypass, mini gastric bypass, biliopancreatic diversion with duodenal switch. And implanted electrical gastric stimulators also will be there. They regulate ghrelin levels.
Okay. What is then coming to laparoscopy point of this case? How do you define laparoscopy?
Laparoscopy is a minimally invasive procedure allowing endoscopic access to the peritoneal cavity after insufflation of a gas to create the space between anterior abdominal wall and viscera.
Okay. What are the advantages when compared to conventional open surgical method?
There will be less handling of tissues in laparoscopic surgery, ma'am. So there will be less stress response to the surgery, rapid return of GI function, reduced post-operative pain and analgesic requirements. So improved post-operative respiratory function will be there, reduced recovery time, decreased length of hospital stay, improved cosmetic appearance, and less post-operative wound infections in laparoscopy compared to open surgical procedures.
What are the intra-abdominal pressures used in laparoscopy normally?
We create pneumoperitoneum with insufflation of gas, ma'am. Initially, we have to inflate the abdomen with 4 to 6 liters per minute, ma'am. Once we reach once the abdominal pressure is 12 to 14 mm, we'll insufflate with the rate of 200 to 400 ml per minute, ma'am.
Okay. So, what is the most common gas used? Ideal gas for laparoscopy.
CO2, carbon dioxide, ma'am. The ideal gas features are it should not cause significant physiological changes, and minimal absorption should be there from the peritoneal cavity. Even though if it gets absorbed, it should be rapidly excreted and should not support the combustion, and should be highly soluble in the blood to minimize the risk of gas embolism. So we'll use carbon dioxide as the most common gas in laparoscopy, ma'am. Air, oxygen, nitrous oxide, as they contain oxygen, they are combustible gases, ma'am. And nitrogen and inert gases like helium and argon, their blood solubility is very less, so they are more prone to gas embolism, ma'am. So we'll use carbon dioxide most commonly because they get absorbed.
Can we maintain the patient in spontaneous ventilation after GA in laparoscopy?
In regional anesthesia, there will be compensatory hyperventilation will be there, man, to excrete raised PSCO2. So regional anesthesia, spontaneous ventilation we can go through as there is a spontaneous ventilation in regional anesthesia, but in GA there won't be compensatory increase in minute ventilation, ma'am. So that will be difficult giving general anesthesia in laparoscopic cholecystectomy.
So in this case, yes, one minute. So in this case, is there any role of spraying the local anesthetic at the post-operative bed, that liver area where the gallbladder has been removed?
Yes, sir. Intraperitoneal installation is beneficial for post-operative analgesia, sir.
Yes, good. Because you have failed in mentioning it. So while presenting, you did not mention it. So that's why I given a tip to you. Okay. Right.
Okay, sir.
What are the respiratory complications, Amma, that may occur in laparoscopy perioperatively?
Major complications are carbon dioxide subcutaneous emphysema, because of extraperitoneal insufflation of gas, they might develop a subcutaneous emphysema. Pneumothorax, pneumomediastinum, pneumopericardium also chances are there. Endobronchial intubation, because due to the Kevlar movement of the diaphragm and carina will shift upwards, so endobronchial intubation might happen, and gas embolism can occur. Aspiration of gastric contents also can occur.
So, what are the hemodynamic changes during pneumoperitoneum?
Because of two reasons, ma'am. One is raised intra-abdominal pressure, and because of hypercapnia. Hypercapnia, as there is a raised PSCO2 level, so it is a stimulator for sympathetic nervous system. So it increases myocardial contractility, it increases cardiac output, increases heart rate, and and causes arrhythmias also. Because of intra-abdominal pressure, there is a biphasic response. If the intra-abdominal pressure is less than 15 mmHg, because of squeezing of the blood from the splanchnic bed, there will be increase in the venous return and increase in cardiac output, increase in mean arterial pressure. If there is intra-abdominal pressure more than 15, there will be compression of the inferior vena cava, so there will be decreased venous return, decreased cardiac output, and decreased mean arterial blood pressure.
Okay, what are the most common cardiac complications which can occur in laparoscopy, and why do they occur?
Most common complication, cardiac arrhythmias, ma'am, because of hypercapnia, peritoneal stimulation, hypovolemia, and venous gas embolism, and because of rapid insufflation of gas and because of peritoneal stretching, sometimes asystole also can happen in these patients, ma'am, lap chole patients.
Okay. Okay. What are the alternatives to pneumoperitoneum for laparoscopy, Amma?
We can to prevent all these changes, because of all these physiological changes because of the pneumoperitoneum, we can go for gasless laparoscopic surgery, ma'am. There we can just lift the abdominal wall to create the space between anterior abdominal wall and visceral organs. Hand assisted laparoscopies are also there.
Okay. Why is nitrous oxide avoided in these cases?
There are three reasons, ma'am. One is nitrous oxide, it increases the pulmonary vasoconstriction, so we have to avoid in obese people. And nitrous oxide, it distends the bowel, ma'am. So surgical point of view, we should not use nitrous oxide. And as it is and if any gas embolism occurs, it increases the bubble size, ma'am, nitrous oxide. So it's better to avoid nitrous oxide.
So, what are the effects of positioning in laparoscopy? What are the different positionings in laparoscopy, and what is it here in this case?
Laparoscopic cholecystectomy will do in reverse Trendelenburg position, ma'am. That is a head-up position. In reverse Trendelenburg position or head-up position, venous return will be reduced. And there will be reduction in mean arterial pressure, ma'am. But respiratory improvement will be there in reverse Trendelenburg position. If we put the patient in Trendelenburg position, that is head down position, venous return will increase. There will be increase in cardiac output and mean arterial pressure. But because of capillary shift of the diaphragm, FRC reduces and V by Q mismatch and hypoxia occurs in Trendelenburg position.
What are the precautions to be taken in positioning during laparoscopy?
Adequate padding should be done, ma'am. And after that, if we adduct the arm too much, ulnar nerve damage will be there. On the OT table, we have to strap the patient because we'll put head up or head down, steep position, ma'am. And after that, we have to be careful with the intravenous lines, ma'am, because we have to use extension tubes also. Because in head up position, head down position, sometimes we may not be accessible. Intravenous lines may not be accessible to us to give drugs, so better to use extension tubes also.
So, suppose during the laparoscopic surgery procedure, the patient suddenly collapses hemodynamically. What could be the reason? What will you suspect for this sudden hemodynamic collapse?
There might be hemorrhage, ma'am, because for major vascular injuries during trocas or various needle insertion, aorta or common iliac vessels, accidental injury might happen to these aorta and common iliac vessels, and the minor vascular injuries can involve the abdominal wall vessels, ma'am. Pneumothorax might happen because gas enters into the thorax because through the facial planes or through a tear in the peritoneum or parietal pleura during the dissection or due to rupture of already existing emphysematous bulla. So this can be associated with pneumomediastinum subcutaneous emphysema. Initially it will be asymptomatic. If we give too much tidal volume with PEEP, it will progress to tension pneumothorax. In both cases, in hemorrhage and pneumothorax, in these cases, sudden hemodynamic collapse will be there in laparoscopy.
How do you identify the embolism?
Gas embolism, there will be a sudden fall of saturation will be there, sir. Sudden fall of EtCO2 will be there, and Millville murmur will be there on patient.
What is the best mode of detection of venous air embolism? Earliest detection?
Transesophageal echocardiography is best, ma'am. It recognizes even minute amount of my ml of gas also. Transesophageal echocardiography.
So how do you treat it?
We'll place the patient in Durand position, ma'am. That is head down and left tilt, ma'am. So that we'll trap the air bubble in the left atria. So it main aim is to prevent that gas bubble to enter into the systemic circulation and pulmonary circulation.
Sir, Jaidir sir, Manjula madam, you can go ahead with any more questions, sir.
No, we are done. Actually, she did a very good job. Should appreciate it. And,
Manjula madam.
Very good and lucid discussion by you and your student. I just want to add one or 2 points. As she said in the case presentation, MET 4 when the obesity is class 3. I just have some question on that, some doubt on that. And another thing is when she mentioned about percussion with this much of thick chest wall, the tympanic note will be a question.
Yes.
Okay. And another thing is very good, otherwise very good presentation by you. Another thing is like to add on, to prevent the atelectasis, the recruitment maneuver, as you said, that inflation pressure up to 50, you said. Another thing is PEEP. When we are using PEEP, every hour, you have to increase the PEEP up to when it is already baseline will be 5 PEEP, right? So you have to increase to 10 for 5 to 10 breaths, increase to 15, then you come back to normal. So in that way, you can reduce the atelectasis and helps in the recruitment. In any cases, like whenever you have or you are thinking of this basal atelectasis and restrictive lung diseases. And another thing is when you are see in these cases you are not using nitrous oxide, right? So when you are reversing the patient, you need not go for 100% oxygen. You can continue with the air and oxygen only during extubation. Up to 40 to 60% of oxygen is enough. Okay. And for pain, always consider preemptive analgesia.
Yes.
And for laparoscopic shoulder pain, you said, and about this preemptive analgesia is always better. And even installation of steroids into the abdominal cavity or IV helps in preventing the shoulder pain.
Okay.
Okay.
Apart from removing all the gases before the port closure. Otherwise, it was excellent. So I think we can end, Dr. Praveen.
Yeah, if there are no other questions, we can end, ma'am.
One question I asked the student, Mr. Ravin. I'll ask one question to the student. What is a goal-directed fluid therapy? What do you mean? How to monitor it? You told a goal-directed fluid therapy. What do you mean that one?
We'll check the response or how the BP is increasing, and according to central, we can use a central venous pressure line also. If adequate blood pressure is there, we can maintain at that rate of fluid rate.
Not the blood pressure, madam. The goal-directed therapy is not the blood pressure. Not the CVP. CVP not the surrogator of the blood volume, it is body fluid volume. Not surrogator. What is the volume they say? It is static. Yes. What are the other parameters to monitor the goal-directed fluid therapy?
Read. Goal direct
Stroke.
therapy is not a blood pressure maintains or a
Stroke
CVP
volume
maintains.
variation we can say, sir.
Stroke volume variation, pulse pressure variation, and ultrasound length. Monitoring the from A line to B lines. Those are the guidelines. Whether you can stroke volume can be measured by transthoracic echo or if you already cardiac index monitor, cardiac out monitor, you can get a stroke volume. Otherwise, simple PPV is a simple thing. When you put arterial line, you'll get the pulse pressure variation.
Yes, sir.
It's a goal directed therapy, not the maintain the blood pressure. Maintain the patient already has a, you told in pathophysiology, the patient is always hypertension.
Okay, sir.
The patient is not the maintenance of the blood pressure. And also, most important is intra-operative to prevent the DVT. Intraoperative, what is your measures you will take? Let's say obese patient, what measure you take it?
Hypertension we have to prevent, sir. Venous stasis we have to prevent.
Not the hypertension. I am asking preventive methods. Not the simple hypertension. All the books reading, the books are giving use a sequential compression devices.
Yes.
Pneumatic compression devices.
Yeah, that is the most important to prevent the DVT, not the hypertension. Sequential compression device or stockings. Most of the sequential compression device, such as obese patient, not the stockings.
Okay, sir.
Okay.
Okay, sir.
Okay. Thank you.
Can you use latest second or third class of LMA to anticipate difficult intubation in this case?
Procil LMA second generation we can go for, sir, because it provides a high seal pressure to prevent aspiration, because obese people and lap chole patient laparoscopic surgeries, they increases the chances of aspiration. So second generation LMAs we can use.
How do you test oropharyngeal leak in this LMA?
In ventilatory settings, we can see the leak, sir.
There is a procedure. There is a procedure. You give 100% oxygen. You take into manual mode. You give a fixed gas flow of 3 liters and see whether absence of audible leak or plateau pressure, airway pressures, or oral capnograph plateau. It is usually 20 to 30 centimeters of water.
Okay, sir.
As we are already running late, it's 9:15. The postgraduate has done a wonderful case presentation and very well explained both obesity and laparoscopic procedures. So today we had two major case discussions for exam going postgraduates. Hope it would be useful for everyone. I thank the examiners for this case, Dr. Subbulakshmi ma'am, Jaydeer sir, and Manjula Ramsali madam for giving their valuable inputs and excellent presentation by the postgraduate Amala. We'll end this session now. Thank you.
Thank you, Amala, for nice presentation. Thank you to
Thank
all.
you, everyone, for your valuable time.